Ashok, should we?
Yeah, I'm connecting. Just a
Yeah.
minute.
Shailesh, you do the introduction, welcome, and introducing the first speaker. Huh?
Yeah.
So we are live now. And
Yeah. Thank you, Dr. Sham. Good evening, everyone. We are here with Spine Connect's fourth webinar this month. This is the activity of Pune Orthopedic Society and Pune Association of Spine Surgeons. I welcome you all for this interactive case-based webinar on dilemmas in spine surgery. We all know, we all face with different dilemmas in lumbar spine. Sometimes there can be a simple problem as adjacent segment disease, when to fix it to pelvis, sacrum, when to stop at L1 or when to proceed with higher levels, what should we do with a lesion in lumbar spine, how we deal with lumbar discitis, how we deal with any complication during lumbar spine surgery, because lumbar spine conducts 90 to 95% of practice in general for lumbar spine in spine surgery. So I would like to request for keeping your questions on. If there is any question, you can definitely shoot it through. We have sent our numbers across and we will try to cover as many questions as possible. Today, I would like to introduce the faculty. To begin with, Dr. K.V. Menon. We all know K.V. sir as one of the stalwarts and legends in spine surgery. Dr. K.V. Is instrumental in doing significant work in deformity and degenerative spine. And we are lucky to have you. Dr. Menon is presently working at Bharati Vidyapit as the head of the Department of Spine Surgery. We welcome you, Dr. Menon. We have our next faculty, Dr. Abhay Nene. We all know Abhay. We should not talk too many things about Abhay, as we all know Abhay is extremely fine as well as academic front, and he's one of the instrumental guy for research and academics in India. We welcome you, Dr. Nene, who is practicing at Leelavati and Richmond Hospital in Mumbai. Our next speaker is Dr. Vishal Peshettivar. We all know Vishal as a minimal invasive surgeon and doing phenomenally good work in Reliance Ambani Hospital in Mumbai. Our next speaker is Dr. Rupinder Chahal, who is the vice chairman at Sant Gangaram Hospital, Delhi. And he's also a true academician. And we all see the amount of activities he's doing for AO Spine. And we really are thankful, Rupinder Chahal, for giving us time for today's webinar. None other than Dr. Anand Tambe, who is our international master for this webinar, who is always there as a strong supporter, who is practicing in Manchester as the head of the unit for adult and pediatric surgery. And he's been always a super supporter for us in even AO Spine Scoliosis Week. He always gives us time for these academic fees. We welcome you, Anand, for this webinar and looking forward for such many in future. We have Dr. Bahuk Garg. We can say North Star of India. Bahuk is one of the prominent figures in India who is doing phenomenal work in academic research, difficult deformities, and we are looking forward for a great association as well as interesting cases from you, Bahuk, today. We have Dr. Shivan Maria, who is practicing currently at Manchester, and he's working in Salford Hospital in Manchester, and his interest also is deformity as well as degenerative spine. He's teamed up with Dr. Anand Tambe in Manchester, and we welcome you, Dr. Maria, for today's webinar and looking forward for such interesting scenarios in future as well. We have Dr. Neeraj Gupta, who is again our North Star, practicing in New Delhi in Indian Spine Injury Center as head of the unit. Neeraj will be joining soon as there is some technical issue, but looking forward for Neeraj's contribution and great cases today for basic knowledge. And last but not the least, Dr. Samir Ruparel, who is practicing in Mumbai. He is practicing at Global and Jaslok Hospital. He is also emerging eminent spine surgeon, very thorough academician, and looking forward for Samir's cases also. Today, I would like to thank Dr. Ashok Sham for his continuous support for our Spine Connect and Pune Orthopedic Society President Dr. Narayan Karne sir, who is a strong support for doing these kind of activities with us. And we're looking forward for webinar to start in some time. And I would request Dr. Karne sir to say a few words. Over to you, Karne sir.
Unmute yourself, sir.
Yeah, I unmuted him actually.
Good evening, everybody. On behalf of Pune Orthopedic Society, I welcome all faculties and the viewers also. First of all, I should thank Dr. Shailesh Hadgavkar, our own. He is also Pune Orthopedic Society Executive Committee member, and he has given us the academic feast for last 2 months. He's very dynamic, enthusiastic, hardworking, and sincere master spine surgeon who has helped with all the faculties or all the viewers to deal with their spinal issues, right from the osteoporosis, disc listhesis, implants and implant failures, spinal lesions, and even for the revision spine also, whether it's for the recurrence or it is a residual one. Well, that all things have cleared our queries and updated our knowledge up till now. Now, today we are having the last webinar and the big academic feast for the many spinal dilemmas which we face during our practice, whether to go for open micro miss, whether if there is a post of discitis, post of leg pain, leaking wound, then what to do, and while fixation also whether we should fix S1, S2, or in the wrong fixation whether we should stop at L1 or go above that. And to enlighten us with this, we have got the international master from Manchester, Dr. Anant Tambe. Thank you, Tambe sir, for sparing your valuable time to this Pune Orthopedic Society as well as Pune Association of Spine Surgeon venture. Then we have another international faculty, Dr. Shivan Maurya, and the masters from Delhi and Mumbai, and our own Dr. K.V. Menon. Welcome our faculties, and thank you very much for sparing your valuable time for us. Thank you.
Thank you, sir, for your constant support and looking forward for such many interesting academic feasts in future. We would like to start our webinar with Dr. K.V. Menon. Menon, sir, would you like to share your screen, please? Dr. Menon will be talking about some basic tips about disc and basic science about disc and lumbar canal stenosis, and followed by an interesting case in lumbar T-leaf. Over to you, sir.
Okay, let me just see if I can share my. Okay. Okay, can you see this screen?
Yes, sir.
Okay, so thank you, Sailesh. Thank you, Anand, and thank you, Abhay, and the entire team. Dr. Karne, it's a great pleasure to be with you. So what I'll do is I'll spend 5-6 minutes with some basics interaction on lumbar canal stenosis. Why lumbar canal stenosis? Perhaps it's one of the commonest surgeries that we spine surgeons do in our country, at least. Whether it is a minimally invasive procedure or a standard laminectomy or laminectomy with PL fusion, with A-lifts, T-lifts, O-lifts, whatever magic surgery you want to do, still the basic pathology that we tend to address is lumbar canal stenosis. I just want to start with a few questions. This is something that I want you to all think about and keep the answers to yourself. This is not a forum. This is not a medium where we can interact very easily. But just think about it, okay? So the first question is this. This whole talk is based on 3 questions. So the first question is this. The clinically most relevant or significant radiological measurement in lumbar canal stenosis is the AP diameter, the transverse diameter, the area of the spinal canal, the diagonal diameters, the foraminal heights, the foraminal area, or the canal to cord ratio. So there are lots of publications out there, and each one of them has shown that one or the other is got clinical significance. So which is the one which has got maximum relevance to a clinical patient who comes with lumbar canal stenosis or neurogenic claudication in your practice? So that's the question. Think about it. If you have any very pressing ideas, you can put it on the comments. Okay. The second question that I want you to think about is the ligamentum flavum tissue undergoes hypertrophy. This is a response to the degenerative disc disease and the segmental instability that follows. Okay, is that true or not? So keep thinking about it, and if you have an opinion, you can put it in the chats or in the answers, and we can look at it later. Okay, so the ligamentum flavum undergoes hypertrophy, and this hypertrophy is a response to the DDD and the loss of height and the segmental instability that arises there. And the last part is in lytic spondylolisthesis, which is something very common and that we operate, the lateral recesses as well as the central canal are compromised as a result of the vertebral translation. Okay? So in lytic spondylolisthesis, not other spondylolisthesis, in lytic spondylolisthesis, the central canal as well as the lateral recesses are compromised. So I'll just explain the literature on that and the basic science related to that so you can try and understand this whole problem a little bit better. I want you to go to this publication. This is July 2012. The Radiological Society of North America has published this particular paper. It is from a group called the Lumbar Spinal Stenosis Outcome Study Working Group, which met in Zurich in July 2012. This consisted of over 100 radiologists. In the last round of the Delphi survey, they had 41 neuroradiologists and musculoskeletal radiologists, and they published the radiological criteria for diagnosis of lumbar canal stenosis. And it's interesting to look at those results. They identified 12 parameters: the AP diameter, cross-sectional area, mid-sagittal diameter, oblique diameter, lateral recess height, cross-sectional area, blah, blah, blah. They looked at several things: the canal cord ratio, the dural sac, etc., etc. And the consensus of opinion was that none of the quantitative criteria would actually correlate with clinical features of lumbar canal stenosis. Whereas some of the qualitative criteria, for example, a disc prolapse of lack of epidural fat or a hypertrophic facet joint or absence of CSF around the chordae equina, hypertrophy of the ligament flavum, all these, they are qualitative criteria. They can correlate with lumbar canal stenosis, but none of the quantitative criteria, none of the AP transfers of this is for lumbar canal, not for cervical canal. Huh? For cervical canal, some of them do actually correlate. For lumbar, none of them correlate with lumbar canal stenosis. What it means is that the picture on the right-hand top is a patient who had severe symptoms. It's only mild to moderate stenosis, but the patient had severe symptoms of neurogenic claudication and required surgery. The second case, shown at the bottom, has got almost a pinhole stenosis, very narrow stenosis. She's living very happily with it. We offered her surgery. She's not very keen to undertake the surgery because she doesn't feel she needs the surgery. She's managing happily ever after. So the radiological parameters, none of the quantitative criteria will form a diagnosis of lumbar canal stenosis. Remember that. Yet, the pathological criteria are still there. Out of several pathologies that cause stenosis, 3 of them are basic. Degenerative disc.
Thank you so much.
Of the ligamentum flavum and facet arthrosis are the 3 primary things that that matter in LCS. All the others, the osteophytes, the listhesis, the synovial cysts, etc., are secondary. The primary are degenerative disc with loss of height, ligamentum flavum hypertrophy, and the facet joint arthritis. Of these, the ligamentum flavum hypertrophy is extremely crucial, and I want you to look at this a little more carefully. You can actually see on this picture on the left side that the disc is degenerate and loss of height. The foramen are significantly narrowed, but look at this, look at this structure which has been pointed out by the arrow, this cream color structure, that is the thickened ligamentum flavum. The ligamentum flavum on the sagittal section in a pathological specimen of degenerative disc disease, you can see how thick, hypertrophic it is and how much it is infringing on the foramen. So it is not only the foramen, if you look at the image on the right side, you'll see how thick the ligamentum flavum is and how the central canal has been invaded by this thickened ligamentum flavum. So is this really hypertrophy? So the picture on the left side shows you the normal ligamentum flavum. The normal ligamentum flavum is composed of elastin fibers, 80 to 90% is elastin fibers, and the rest is collagen, type 1 collagen. And this is from Dieter Grob's study, very old study, 1999. So you can find in that study what actually happens in lumbar canal stenosis is the normal ligamentum flavum here becomes degenerate, and when it degenerates, the normal linear pattern of the ligamentum flavum is lost. It becomes irregular and it becomes multidirectional, number one. It is randomly or haphazardly arranged, the fibers, number one. And number two, the elastin fibers are replaced by type 1 collagen fibers. 80 to 90% of the fibers become type 1 collagen fibers. It does not mean that the cells hypertrophy, the fibroblasts do not hypertrophy, they do not undergo hyperplasia, but they only undergo degeneration and replacement by type 1 collagen or the scar tissue. The other thing which is shown in the cartoon is on the left side, because the interlaminar height is maintained, the ligamentum flavum is held very taut because the disc height is maintained. But once the height is reduced, the lamina come close together and the ligamentum flavum buckles on itself and increases in thickness. It accordions on itself and apparent thickness is increased. There is no true hypertrophy or no true hyperplasia of the ligamentum flavum. And this is the reason why indirect decompression, whether by T-lift or O-lift or A-lift, will stretch, will restore the interlaminar height and therefore stretch the ligamentum flavum, or even interlaminar spacer devices will restore the interlaminar space. It will stretch the ligamentum flavum and restore the spinal canal dimensions. So that was the answer to the second question. There is no true hypertrophy or hyperplasia of the ligamentum flavum happening. And this is the third question. Please look at these three images. These are three increasing grades of pars defect and spondylolisthesis. Spondylolisthesis due to spondylolysis. And if you look at the normal foramen is comma shaped and it's got vertical height more than the transverse height. But as the listhesis progresses, the disc space is narrowed and the transverse diameter of the canal increases and the vertical diameter of the canal decreases. And this is what happens in all lytic spondylolisthesis. Yet, if you look at the axial section, the spinal canal dimension in the central canal dimension in the AP direction actually increases at the level of listhesis, and not vice versa. The central canal dimension does not decrease in lytic spondylolisthesis. Is this important? Yes, it is important, because many of us are taught that the Gill's procedure is a fantastic operation to do, where you take out this loose rattler and imagine that the spinal canal stenosis gets better. No, the stenosis is a foraminal stenosis and a far out stenosis here. You cannot really address this by taking out the loose rattler alone, and therefore we need to be aware of that. So the summary of what I have been trying to tell you, the three questions that I asked you in the beginning and the three answers form the summary. The spinal canal dimensions have no linear correlation with the symptoms of clinical stenosis. Radiological dimensions do not correlate. None of the quantitative parameters correlate with clinical lumbar canal stenosis. That's number one. And true hypertrophy or hyperplasia of the ligamentum flavum is unlikely. What happens is degeneration and replacement of the elastin fibers by collagen fibers, by type 1 collagen fibers, and the random orientation of those collagen fibers, and the buckling of the and accordioning of the ligamentum flavum that happens because of reduction of disc height. And the last is in lytic listhesis, there is very little central canal stenosis that occurs. Most of the stenosis symptoms that you get is probably a lateral and a furrowed stenosis, not really central canal stenosis. So we should be careful about that. So I'll just stop here for a moment before I go to the case. And if any of the faculty want to discuss anything more about this, I'll give them the opportunity. Sailesh, can you?
Yeah, sir, very well said. I was talking to one of the faculties from Europe and Finland. They were talking about the lumbar canal stenosis and patients who come to their clinic. Their experience, they were sharing that they were fusing the spines without doing any decompression in this severe stenosis. And they were telling at least one and a half years time, they were getting that stenosis is completely relieved. No need of decompression was their concept. I was really taken aback, but when I saw their work, I realized probably there is something which they want to talk about. And as you rightly said, there is nothing like hypertrophy, probably buckling, and the motion is causing that. Any other comments, Abhay?
Bauk?
Yeah, yes. So we have just published, the ligamentum flavum morphology, electron microscopic and histopathological this thing between degenerative stenosis as compared to the young individual in Asian Spine Journal this month only. And we have found that quite a lot of people, especially after the age of 60, they also develop chondroid metaplasia. So if there is an element of chondroid metaplasia, so that doesn't stretch. That can be, the cause of remaining stenosis. But yes, the majority of the reason it remains not hard part, so it can be stretched. But if there is a chondroid metaplasia, so after the age of 60 years, we should be a little bit cautious because that chondroid part it cannot get stretched.
I would tend to agree, KV. When we actually feel the ligamentum after the osteotomy in elderly severe stenotics, you find it hard, and on your hand, it doesn't feel soft at all. What do you have to say to that?
Yeah, so when you're doing an indirect decompression procedure, it has to be in a relatively young patient where the ligamentum flavum is a large part of it is chondroid metaplasia. As Bhuvak said, we have read that paper. That's a fantastic paper. There is also an osteoblastic change can occur. There have been publications which have shown that in the thoracic spine, osteoblastic transformation can also occur within the metaplasia can occur within the ligamentum flavum. So all these do occur. So in those instances, perhaps it's a smart idea to just remove the ligamentum flavum and if indicated, the lamina as well. But the ligamentum flavum probably does not stretch as much.
Right. So this debate will go on, but I think you've shown a lot of, from literature, you've shown us what is the correct stand. And Bauk, your input was also very important. Can we move to the case, KV?
Yes.
Jump into your case. Can you share your screen?
Yeah. Just give me a second. So can you see this now?
Yes.
So this is a case that I had quite recently. This is a 63-year-old man. His main complaints were low back pain, which has been going on for about a year. He also had right lower limb pain for the last 8-9 months. His walking distance is about 100 feet. He says he has to bend forward, stoop, or sit down after that. On examination, he had a classical extension catch. His SLR was normal bilaterally. He has no sensory, motor, or reflex changes in the lower limb. He is hypertensive and hypothyroid on medication, has been for a while. Okay, so this was the patient. That's his X-ray, MRI, both the sagittal T2 as well as the axial section. The X-ray shows that he's got very subtle instability at L4-5. I think there's probably a 0 to 1 list. This is there. The MRI shows that L4-5, there's significant stenosis. The axial section, in these two sections, you can see that there is quite a lot of stenosis. It's a single segment stenosis. There's nothing below that. There's nothing above that. So it's a very straightforward case. At least I thought it was a straightforward case. So he underwent a conventional TLIF at L4-5. He had immediate symptomatic relief. He was mobilized the very next day. I must point out on the AP view, you can see this, one of these screws are looking very undesirable to my mind. That's not good at all. But his pain had substantially reduced on the next day. We mobilized him next day, discharged him on day 3 after drains out with oral analgesic, and his further course was completely uneventful. He was reviewed at 6 weeks and he was completely asymptomatic. He was walking, he was bending. So we started his rehabilitation with spinal exercises. At 2 months, he came back and he said he's got severe low back pain and he's got some pain in the right thigh, but his walking distance was normal. His claudication symptoms were relieved and he was walking quite comfortably. He did have some burning micturition, therefore we did some urine tests. His blood tests were quite uneventful. His ESR was raised, CRP was raised, procalcitonin was negative. Blood culture had no growth. His urine showed some pus cells, but the culture was negative. Yet, because of his ongoing pain, we went and did a CT scan and bingo. Now the CT scan is looking a little bit alarming. I was a little bit upset by looking at that CT scan. It shows end plate erosions, which suggests a low-grade infection. And though the culture was negative, the blood culture and other cultures were negative, we did not do any invasive procedure or aspiration. We started him empirically on an antibiotic. We admitted him, started him on a course of IV antibiotics, and remarkably better. His pain reduced very rapidly. In about 4 days, he was ready for discharge. He continued his IV antibiotics for 3 weeks. And at 3 weeks' time, his VAS score had reduced to 3 from 6. His ESR and CRP were diminishing, and therefore his ESR now was 48, CRP was 21, his total counts were then reducing. But the X-ray at this stage showed that the cage has started migrating backwards. That's not looking good at all. But he did not have any radiculopathy. His back pain had reduced substantially from 6 to 3. A week later, he continued his 6 weeks of antibiotics. He was completely asymptomatic. We stopped his antibiotics and sent him home. And he was quite happy with that. He came back a week later, his second episode of severe back pain, typically instability pattern of back pain. He said his VAS score was around 7. At this stage, we said, you know what, this is a stinker. I think there is infection ongoing. We better revise it. We better take out that cage and revise the implant and possibly put some bone graft, etc., maybe antibiotic, locally antibiotic, etc. He was unwilling. His TLC was 13,000, ESR was 58. He was again put on another course of Augmentin. His blood cultures again at this stage were negative. His urine culture was not done at this stage because he was asymptomatic as far as urine is concerned. So we put him again on a course of IV antibiotics for a week. Again, Augmentin was chosen. After a week, his VAS score again came down to 3. His back pain was completely relieved or substantially relieved. He's not taking any analgesics. He shifted to oral antibiotics. He's continued that for 2 more weeks. And he is now 3 weeks of oral antibiotics completed. His total count is 12,000. ESR is 37. CRP is there. He's clinically better. His VAS is 2. He's walking. He can bend. He can do his household chores. Everything is good. He's very happy. He doesn't want to think of anything further. And his pain is completely gone. Now, the problem is he's 5 months post-op. That is his latest X-ray. The lower 2 screws, to my mind, are looking loosened out. The upper 2 screws, I hope, are holding. The cage is retropulsed, and that's looking terrible. And he's had 10 weeks of empirical antibiotics, all with Augmentin. And this is where we stand now. So, what are the issues? How do we proceed? Will it spontaneously fuse? Given the natural history of spondylodiscitis, whether it's pyogenic discitis or tubercular discitis, vast majority of them, if you treat them conservatively, they undergo spontaneous fusion. So will this undergo spontaneous fusion? This patient.
Let's quickly run this through the faculty. KV, if you don't mind. Anand,
Yes,
can you unmute?
Yes.
Sure. I want the faculty to answer this.
At this point, what do you think? Are we doing the right thing, or we should be jumping in and forcing him into resurgery?
I believe in this Elizarov statement. I think this whole construct is inherently unstable because the L5 screws are both not really holding the L5 vertebra. The screw on the right side of the image was, sorry, I'm being very critical here. Probably not doing too much of a job. The one on the left side of the screw is also now loosened out. So I think one of the basic tenets of infection control is, as Elizarov said, infection burns in the fire of stability. So I think I would actually get a CT, see where those screws are placed, and my plan would be to do a revision where I take out the bottom two screws, replace it, and get the cage out. And
Anand, the question is slightly different. Here, the surgeon wants to do a revision, but the patient is totally refusing because he's getting better. And he sequentially come to, 5 months post-op, improving
so I
to
would
3
still
on
tell
10.
him, that you might be better now, but this is progressively getting worse. The screw position is changing over the series of implants. I think the cage also has backed out more. So the issue is to tell him that this is a progressive situation. He might not have a problem now, but there's a reasonable chance that he might develop a problem later, and at that
So
time,
you would weigh on him for a redo. Basically, you
yes.
would push him. Vishal, would you agree? And anyone else
Absolutely.
in the faculty who
Can I
disagrees,
just
please
ask
unmute. Yeah.
Anand,
Can I? Sorry.
revise, would you consider the same segment, or would you consider revising it downwards or upwards or both?
I would stay at the same segment. I think we should be able to get a good revision at the same segment.
Okay.
Right. Vishal?
Okay, the first thing is I would never start an empirical antibiotic where I'm suspecting pyogenic infection. If a CT scan was done, it's very easy. Just under fluoroscopy, go to the cambium strangle and sample the disc space. Get a proper antibiotic. This thing. If you don't find an empirical, honestly, we don't know what is around the globe. It is usually gram-positive bacteria, but in India we find gram-negative rods, which are in our hospital. 98% of the infections are gram-negative rods, and the infectious diseases policy is very clear: get a sample, culture it, and only then start antibiotics. We stop all our antibiotics at 48 hours. So that
Right.
The reason
Right,
we
Vishal,
get
now
them.
that done, we got the point that we should do empirical and get to the, in this scenario, patient recovering, patient stabilizing, but the X-ray looking bad at 5 months post-op.
So we are sitting on a time bomb. This needs to be revised. Having said it, it is extremely difficult to convince Indian patients for the first surgery. The second is going to be very difficult. But I would do my documentation and keep the paperwork, keep a copy of the paperwork, and that he was advised
Right.
surgery and he
Right.
is refusing it. But I would weigh on him that if he wants his way of treatment, he should seek it somewhere
Right,
else.
fantastic. Anyone in the faculty would like to conserve? Anyone thinks differently? Any different
I
ideas?
just want to
Bhau?
highlight
Yeah,
what
so-
I just said. That's a very important point of not starting empirical antibiotic without obtaining a culture sensitivity. I mean, that's a take-home message. One of the take-home messages, one of the important take-home messages from this particular case.
What's your difference of opinion here?
So I think, if something is working, then I shouldn't touch it. If the patient is improving, so I will have a close watch. I will prepare him for the surgery and everything. So if his symptoms worsen in this thing and the reports, they also go towards CRP also increases, then I will again go for surgery. But if symptoms are improving and he has no symptoms, so I would like to have a close watch and conserve.
Right, that's fantastic. Anyone else agrees with Bhau? I'm
Abhay,
personally on
think,
that side.
Abhay,
So,
I think,
Ruben,
I
just one intervention, one comment. I personally believe if you want to conserve, then the way to go is to give at least 6 weeks of IV antibiotics and not 3 weeks. And after 6 weeks, you may consider, depending on how the ESR CRP is coming down, to convert to oral for a total of 12 weeks because it's empirical. At least
Right.
6 weeks are IV. That's the rule we
Right.
follow.
And
Dr.
add
Chahal?
Fampicin
there
as
are
well.
two things. I think what Vishal said is getting a sample. At times you don't get a sample. So better in that case is look at the antibiogram of the hospital. What is the prevalent infection and start those. And moreover, when the cage has started backing out, I think it is time you take it off and redirect your screws. We have burnt our fingers by pushing this cage 2-3 times, but it has again come back even the second or the third time. So I would rather revise the screws, take out the cage and fill it with a bone graft.
Right. Dr. Shailesh, your final word before we pass it on back to Dr.
No,
Mehta.
I think there are two things to look at it. Yes, patient is not very keen. Patient is improving. Probably sometimes give instability a chance. That's what I feel in this scenario. And maybe very close watch, and probably this will settle, and we probably will get away with the situation.
So that's 3 of us on the wait and watch list. Yes, Dr. Menon, over to you again.
Just the question I asked in the beginning is the same. if you are treating a pyogenic infection or a tubercular infection conservatively with appropriate antibiotics, in this case, Vishal pointed out our antibiotic is empirical. That's true. If you are treating it with an appropriate antibiotic, the natural history of the disease is spontaneous fusion. Can you expect such a spontaneous fusion to happen at this stage? That was my question in the beginning.
So KV, can you hear me?
Yeah, sure.
Yes, yes.
So I agree with you on the point that spontaneous history of a pyogenic infection is fusion, but that is actually proven to be only the case if it's Staphylococcus aureus causing pyogenic infection. There is now good evidence that if it's less likely, but if it's gram negative, they actually cause progressive bone destruction and they do not go to fusion very often. So, because we are doing this empirically, we don't know whether it is gram positive or gram negative. In that case, I am not sure if it was pyogenic, whether it would go for a fusion or spontaneously.
That's a very good
Right.
point. It's a very good
Right.
point.
When there is a cage lying there, the end plates are written, there is no bone or bone graft. Where will fusion occur in this case?
That's a valid point as well. But I think with the two of those things,
Fantastic. So do we have any further solution, KV, or that's that?
So at the moment, we are just following the patient and waiting for him either to have pain again when we try and persuade him to have the surgery, or to come with any radicular symptoms or leg pain, in which case we'll try and persuade him again to have the surgery.
Fantastic. Thank you, KV.
Yeah. If the
Dr. Karne, can you quickly come in here and tell us, in your orthopedic practice, would you push him for a redo, or would you have just conserved him?
Exactly. That's what I was going to say. I fully agree with Shailesh and his colleagues who are not going immediately for the operative intervention. See, what we want is a relief of the pain. We are not yet sure whether the infection, how much infection is there right now. Because in the florid infection, the patient doesn't get any relief, then we can go for operative management. As long as patient is happy, he's carrying on his work. Let X-ray. We'll follow up him on X-rays and the CTs which is required. But then we'll operate only when the patient is severely symptomatic and patient should demand the surgery, then we should offer him surgery.
Right. Very useful. So we'll quickly switch to Shailesh, if you don't mind. We'll quickly switch to the next scenario.
Abhay, you can.
This is the next very common scenario, and I'd like someone from the faculty, maybe Shivan, you've not spoken yet. Do you find anything suspicious in this simple LCS? Something technical, anything you feel to look for during surgery? Samir or Neeraj, any of you can also comment.
Is there a facet cyst on the right side?
Yeah, so we're actually talking about this thing here, isn't it?
Yeah, that's what I was talking about.
So what do you think it is? Samir, you can come in also.
Yes, I agree. There's probably a facet cyst on the right side. Also, there is partial sacralization of on the sag.
Yeah, sure. So just the point, Neeraj, do you think it's a facet cyst, because it should look bright on T2, a facet cyst? This is looking very black. Unless you can, yeah.
How does it look on T1? Because if it's a calcified facet cyst, then it will look dark on both T1 and T2.
Right. So basically, I'm alluding to the fact that this could be a calcification there, isn't it?
Yes.
Rather than a cystic presentation. Whether it's Neeraj, you're muted, Neeraj.
Oh, sorry. So it could be phlegm calcification also, something like some calcified lesion there.
Yeah.
Or as the sir said, it could be some calcified cyst or some calcification is there.
So I think that's what I wanted to put across, that in a case like this, you should be always careful of going on that right lateral recess, because there's something hard that is sitting on the dura, and that may prove to be your undoing. And sure enough, in this case, the left side was nicely decompressed. As you can see, medial facetectomy and nerve root is very nicely seen. But when you tried to do the same on the right side and pulled out that fragment, see what happens. Rupinder, this has happened to your case now. You're operating intraoperatively. There is, while pulling out the calcified ligamentum flavum, a chunk of the dura actually peeled off, and you could see nerve rootlets sticking out on the lateral recess. What would be your plan? First Rupinder and then Vishal, please.
Yeah, I think probably first I would take away my suction from the operating field before I suck few of them. Yeah.
Right. So take the suction away, or at least discharge the suction. Don't use the ungli. Don't use the finger.
Yeah, put a 3-way or something, control the flow. And
Yeah.
probably then look at how much the damage is done, put few cottonoids and see what it is. Is it a dural rent, or have gone into the root and split the root vertically, because difficult to see from here. And then see how much the damage is. And then accordingly deal with it. If it is, I think the root is well decompressed, and this, I would then probably not take off the ligamentum roof, which is protecting it, and put a Duraseal over it. So it
Okay, we'll come to that. But your first step was keep the suction at low, try to inspect the damage, look at the neural structures, and then consider the next step. Vishal, the specific question to you is, would you pack this area and finish your operation and come back to this, or would you attend to this area first?
If I'm doing an open surgery, I would first open the entire extent of the tear, get hemostasis, isolate it with patties, and repair it. If you leave this open, there is a high chance that the dural sac will collapse. A dural sac has a protective shock absorbing structure for the nerves. The moment the dural sac has collapsed, it is very easy to complete our surgery, but it increases the chance of neural deficit. So first is see, isolate, and repair, and then continue with your rest of the job.
Does anyone disagree with this? Would anyone like to pack this off and finish the rest of the operation and then break your head over the problem? Yes, KV?
Yeah, that's what I do. If I have a dural tear, I tend to pack off that area. Like the previous speaker mentioned, I would expose the area wider to see the tear, the anatomy of the tear, but then I would tend to go and do the main procedure first, whatever I had intended to do first, and then come back and think about the dural repair. Just incidentally, one more point can I just bring up?
Yeah.
That's one of the physical properties of the ligamentum flavum is the ability to not adhere to tissue. And that is from the elastin fibers. The moment the elastin fibers change into type 1 collagen, it will become a scar. It is a scar tissue and it can adhere.
Right. So, Anand, can you quickly come in, and Dr. Rupinder Chahal, would you pack first and do the surgery, or do attend to the tear first? Anand and then Rupinder.
I agree with what Vishal said at the beginning. I believe that though it will be technically easier to do the rest of the surgery, however, if you let the dural sac collapse, there are consequences to it. So I would actually repair it at that point of time, and then go and do the rest of the surgery.
Right, Rupinder, quickly.
I wouldn't do my patch at that point of time, but I would at least reduce, if possible, the size of the rent.
Sure.
Rupinder? I would inspect the damage and probably pack it. So that will prevent what Vishal is saying, the collapse of the dural thing. But I would not repair at this point. I would do my surgery, planned surgery. Probably if I think the rent is too big and I may create more problem, I may probably shorten my other surgical steps or something and finish those and then come back to this.
Right. Samir, what is special about this dural tear? It's something different. As a surgeon, what is worrying you about this dural tear?
So it will be a little difficult for repairing this dural tear, since I can't see the other edge of the dura, so that I can hold it with my stitch.
Right. It's a dural tear that's on the lateral sleeve, and like you rightly pointed, any surgeon would realize that it's one of those ones that are hard to repair. Now we know that it's hard to repair. What are you thinking? How are you thinking in your head?
So yes, and I think it's because of some upcutter or something the injury has happened, or maybe because of the fragment which you're taking out. So it's a ragged edges. So again, the edges, they will be friable and they will be difficult to repair. So I will give it a try if I can see the edges and I can repair it. Otherwise, I will just keep a tissue seal and dura patch ready for.
Fantastic. So quick take home on that front. Number one is that you pack the area around, so get hemostasis. Number two, don't forget, no one mentioned this, get a head low. So the CSF pressure comes down. Immediately put a head low. The third is to try and inspect the damage done and make sure that all the nerve roots are at least packed in, make your suction into a low power suction. Try to look at the edges, and the general dictum is that if you find that there and then it is suturable, suture it off. The advantage of suturing it is that the dural pressure builds up and the rest of the spinal nerve roots get protected. More importantly, you don't undermine your the remaining decompression, because if the thecal sac is floppy, it doesn't represent the amount of compression happening, and hence you may under decompress at the remaining levels. Now, quickly, Shivam, I want to get you in here. How do you plan the closure? Do you normally close with running stitches? Is it is it absorbable, non-absorbable? What needle? Can you quickly give us a tip?
So, sir, I would use a long-lasting absorbable continuous stitch in the fascia. So something like a PDS, and it has to be absolutely watertight. The fascial closure here is of prime importance.
We are talking of dural closure. Dural closure.
Oh, sorry. Dural closure, sir, I would usually use a 5-0 Prolene, and I'd use a running stitch. But then you have to inspect the type of tear that you have. Obviously, if it's a very small tear, high pressure, then usually just a single stitch does the job. This one, again, other than what Samir said, I think from what the pre-op MRI scan also, what you're alluding to is that this is a sort of a avulsion where that fragment has taken off a whole chunk of dura with it. And I mean, I'm trying to see in this video if you've actually managed to get end-to-end repair, because that can typically be difficult in trying to do it back to on the lateral or ventral side.
So 5-0 Prolene on the round body, of course, you were trying to tell us.
Round
body stitch is extremely important.
Yes.
Lovely. Shailesh, any tips and tricks from your vast experience?
No, I think most important is whenever you are doing, you should have a very good bright illumination, light source, either a loop or microscope. That's what I personally will recommend. It's very, very important, and not to lose. One thing is we always try to do one thing is that we keep two or three patties, we roll them and we keep it on the top of the dura. Just subtly we keep it so that the pressure is low. That also adds up for your good repair.
Fantastic. Neeraj, from your experience, any complications of this repair? What things can go wrong in this simple stitching up of the dura?
So first thing is, like in my practice, I in the dural tears, I usually give intermittent stitch. I am not using this continuous stitch. I don't know what is right or wrong, but I am using intermittent stitch.
Okay.
And secondly, your question was what complications can occur?
Yeah.
So complications are first thing is dural leak. Some leak can be there, or sometimes
like you can leave it partly closed only, and then you can develop a high pressure leak from a low pressure leak.
Yeah. So
yes.
that complication can be there, or like
how do you prevent that? Is there a method that you use to prevent leaving a small rent open at the end of your closure? Many of us do the Valsalva maneuver.
Yes,
we ask the anesthetist to blow into the umbilic and look for leak.
Yeah, we are doing that Valsalva maneuver after.
Right. What about an entrapped nerve root? Bhauk, have you had a chance to see that while you're stitching up, part of the nerve root sticks in and the patient gets horrendous post-op leg pain? Can you tell us about it?
So actually we have a technique for that. So as Shailesh pointed out, the use of neuropathies. So if there is a big defect, we actually you roll it up and we just push the nerve root and we put the nerve patty on that. And then we repair this thing, and at the end we just take it out.
Right.
So actually,
anyone else in the faculty, any other complications that you all have seen because of this closure?
Okay. One of the things to worry about, as you said, if the you convert a low pressure leak to a high pressure leak, and if it's not done properly, one of the long-term sequence, if there's a persistent leak, is a CSF hygroma, which one needs to worry about. So if it's a big rent like this, that's one of the things one needs to clear if one doesn't manage to close it properly.
Fantastic. Samir, Ruparel, dural patch or no dural patch? Yes or no?
Yes, sir.
Okay. Dr. Rupinder Chahal, T-seal or no T-seal?
I use dural patch.
No, T-seal or no T-seal?
No T-seal, only dural patch.
Okay. Dr. Maria, muscle patch or no muscle patch?
No muscle patch, dural patch.
No muscle patch. Dr. Menon, can you answer the last three questions on the slide? Would you put a drain? What would your post-op protocol be different about mobilization? And would you extend your antibiotics?
Yes. Before that, I just wanted to ask Dr. Anant, is a hygroma the same as a pseudomeningocele?
No, it's the low CSF pressure which happens and causes a non-communicating hydrocephalus.
Okay,
right.
Fine.
Right. So, KV, would you put a drain?
I always put drain, but then I always put a lumbar drain as well. I put a lumbar drain above for large irregular tears like this. I put a lumbar drain above.
So an epidural catheter, basically.
The only thing is I don't charge the drain. I mean, I don't attach it to the vacuum, or I don't put the vacuum on the drain.
Yeah. So, by lumbar drain, you meant epidural catheter?
Intradural catheter.
intradural diversion catheter for all unclosable dural tears.
Yeah. So the post-op protocol changes because normally I give antibiotics only for 12 hours. I never continue my antibiotics beyond that for any case. I mean, scoliosis included. But in this case, I would continue antibiotics, number one. Number two, I'd keep the patient in bed and I would ensure supplementary intravenous saline or fluids in addition to his normal oral fluids. Then I would start acetazolamide as well. So antibiotics, bed rest, acetazolamide, lumbar drain.
Vishal, I just want two controversial points here. Would you put a lumbar diversion drain, that is a CSF catheter like KV does, in all non-closable dural tears, number one? And number two, would you give acetazolamide Dimox in all cases?
To answer the first one, no, I don't put it in all the cases. In fact, we haven't put a single one in the 22 years of practice that I've been doing. The reason probably is I trained with two guys, Umesh Vensarkar and Rajan Shah, both are neurosurgeons, and both don't believe in that. The only time we would do it is the patient is coming with a CSF leak that is active. Then yes, we have put one drain in that case, but that was a patient who came in after a week with CSF leaking from the wound. Second,
so
acetazolamide.
In a situation like this, you would do an epidural diversion.
I would probably, yes.
Right. And
acetazolamide, no, I don't give it.
Right. Rupinder, quickly on this situation, after everything is done, the patient comes back with a leaky wound. Just 3-4 pearls before we move to the next case by
yeah. So important. First of all, important is, I think, admit him, bed rest, and put a pressure pack bandage. And if still it doesn't stop, and if there is no lumbar epidural there, we would put a lumbar drain.
Fantastic. Shailu, do you want to add something here before we close?
I personally prefer to avoid drain as far as possible because I like to give the tamponade effect for most of this. I personally use dural patch and try to keep them in bed for at least 2 to 3 days and no change of dressing if it is not leaking. And we just try to keep the patient flat preferably, and that's about it. We normally do not use acetazolamide unless some neurologist adds up, but 95% of the time we never used for our dural.
Fantastic. So lots of take-home messages here. Yeah, quickly.
I would like to first confirm that is CSF, not a serous fluid. I would actually send it for a tau protein first. Confirm that it is CSF leak before doing everything, because it might just be a serous drain, in which case you might not need to do anything at all.
Right. On a sobering note, I've had a death in a patient like this who came back much later, week 1. I mean, and in a 1 week post-op with massive secondary CSF leak and got meningitis and died. So let's pass this on to Samir Uparel for the next case, please.
And I think we should not ignore headache in such patients. They get subarachnoid hemorrhage post-leak in some cases.
Yeah.
Right.
Yeah. Perfect.
Go ahead, Samir. Take over.
Yes, sir. So I'll just start sharing my screen. So is my screen visible and I'm audible?
Yeah.
Okay. So a short case basically. She is a 28-year-old lady who is an IT professional and with severe right lower limb pain since last 1 week. And she also has mechanical low back pain with back pain back pain less, but marginally less than the leg pain. The catch to this is that she was operated elsewhere 3 months back with right-sided L4-5 microdiscectomy. And the pain distribution is quite similar to pre-op. She is fortunately neurologically intact. The right SLR is positive. So I would like the opinion of the house at this point. What would be the next step? Shall we just consider this as maybe continue with the conservative treatment, maybe investigate, and if investigations, then which investigations?
Shivan, quickly, what are your indications of investigations in the post-op leg pain?
If she's got a radicular pattern of leg pain, I would consider an MRI scan.
How early?
So we do it right away if necessary as well.
Dr. Karne, are you there? In your practice, if a patient comes back with leg pain, it's your own patient operated 3 months ago, and she comes with leg pain at 3 months after having an initial recovery, What would your plan be?
We go for conservative management initially with the medications and the physiotherapy required rest. But if the still pain persists, then if there is no infection there, then we give epidural injections. And if the still it persists, then we go for MRI scan and then take a further call.
Right. Rupinder, do you have a criticism of this approach where we try to conserve, give
No,
epidural, etc.?
I am very aggressive in this. So first thing I would do is, even if pain is on the next day, we would get an X-ray first. That would give us whether we have done a right level or not, and get the blood test immediately. That will be a baseline, even if they are normal. If the pain is still not subsiding, I will go ahead with the MRI.
Right. Go ahead, Samir.
Yes, sir. So, I mean, we also did, I mean, at least got the investigations done. And these were the X-rays of the patient, the normal AP lateral, as well as a flexion extension. Anything particular?
I think nothing remarkable here except that scoliosis, right?
Yes, sir. Yes, sir. Exactly. Yeah. And we also did a few blood tests where vitamin B12 and D3 were low, and arthritic markers and the rest of the blood tests, CBC, ASR, CRP, everything was normal. So
we noticed you didn't do an MRI scan. Any reason?
No, sir. So at this point, I actually wanted to ask. So considering that we have now done the basic investigations, we'll get the MRI done still, or should we conserve it? I mean, the basic preliminary investigations are normal. So I would like to know whether we should go for the MRI right away, or with these investigations, we should hold on.
Dr. Menon?
Yeah, I think we should go for the MRI. Yeah.
Anant?
I would go for an MRI because the inflammatory markers are not 100% sensitive or specific for an infection, which you could always need to consider, which might be a low grade infection. And obviously you cannot rule out an acute recurrent disc. So I would go for an MR scan. As Mr. Maria pointed out, we would do it even on day one if we had concerns of recurring leg pain.
For the benefit of the audience, can you enlist the likely causes of this situation, post-op leg pain after 3 months of a microdiscectomy?
So the first thing is like we will not go for normal MRI. We always go for contrast MRI if it is a post-op case.
Even at 3 months?
Even if 3 months, because some pathologies, post-op changes, they can mimic disc, and the contrast MRI, it can actually differentiate between the various other causes. So
sure. What are the causes that you're thinking of? Differential diagnosis?
So first comes the recurrent disc in our mind. Then comes especially in this case, then comes any post-op scarring can be there, or it could be some infection, or it could be just some hematoma. It can also be, these are the main causes which I can think of.
Neeraj, how often have you seen a recurrent disc at 3 months in your practice? Just give a percentage number, random 1%, 10%, 50%.
So at 3 months, I think less than 5%.
Not so common.
Rupinder,
what is your impression about recurrent discs? How early? What is the earliest that you've seen a recurrent disc?
They follow a bimodal pattern. Other recurrence, first is some of them reoccur quite early, and some of them after few years you see they suddenly strain, and one large piece of fibrotic annulus will come and hit the root. So it's either very early or quite late.
Fantastic. Samir, go ahead.
So we got the MRI done, we got the X-rays, blood tests, and the MRI. And as suggested, we also got the contrast MRI done. These are the gross films, the sagittal and the axial, and the whole spine screening. And these are the ones. So,
can anyone read this MRI for us? Shivam, are you good to go?
So we can see at L45 there's been a previous fenestration on the right side, and on the same side there appears to be an inferiorly migrated disc which is herniated, and it's compressing the traversing L5 nerve root in that lateral recess. The facets appear quite well preserved.
How sure are you that this is a recurrent disc and it's not a hematoma or a scar or some foreign object?
So, I mean, for scar tissue, it's quite well circumscribed. I don't think it looks very much typically like scar tissue, but yes, to be honest, I would always ask for a neuroradiologist's opinion and to confirm what I think is going on.
Bhauk, your impression, you asked for a contrast MR and you have one.
So you can see that this is if you look at the T1, there is a total, the dark appearance. But if you see on the contrast images, there is a peripheral enhancement and there is a central this thing. This goes in favor of disc.
Right. So it's a very important point here. If you see the image on the bottom right, you'll just see a vague ill-defined mass on the right lateral recess at the L4-5. But if you see the images on the top right, you'll see that mass is a circumscribed ball. And that circumscribed, which is called a halo around the ball. The halo is what lights up. So the contrast is taken up by the vascular tissue, which is actually the scar. A disc being avascular doesn't take up the contrast. And hence this halo sign is a sign that is a sign qua non, as they say, of a recurrent disc. Go ahead, Samir.
Yes, sir. So what should be the next? Shall we continue with the conservative treatment or give a root block or directly go ahead for the surgery at this point?
Anyone, Dr. Karne, would you like to pick on this?
Yeah, but the risk is too big, and if the patient is severely symptomatic, we have to go for operative intervention. The compression.
So you would not give bed rest or injection an option?
No, not in this case.
Right. Dr. Menon?
Unlike primary disc, recurrent discs have a very poor response to conservative treatment. Primary disc, 90% get better with conservative treatment and only 10% require any kind of intervention. But recurrent disc is the other way around. 90% require intervention, only 10% get better with conservative treatment.
Right, Samir. So you heard it from both the experts.
Agreed, sir. And that is exactly what we counsel the patient, that somehow the patient might require a surgery. But anyone for root blocks in the revision case in the panel?
Let's ask Anand.
We would, and in this case, depends on the pattern of the pain. If it's a crescendo pattern of pain and with the size of the disc, and I assume that the patient doesn't have chorda equina type symptoms, not that it's not causing any chorda equina compression. I would tend to err on the side of giving a nerve root block, because invariably the patient is young. One has to worry about the fact that there is a potential chance for a recurrent disc. One can never make it zero, however good your surgery is. So I would, even though I know that the chances of improvement with a nerve block are low, I would try an injection first.
Okay. Yes,
Samir.
So we continued with the conservative treatment. The patient came for follow-up and there was no relief. So obviously we counseled the patient again, and this time the patient agreed for the surgery. So now the question is open to the house, whether this should be treated with a redo microdiscectomy, or we should try a TILIF, PILIF, or some of the newer modalities of treatment, as well as, should we go for an open surgery or an MIS surgery in this?
Maybe we can have Vishal to answer this.
So, does the patient have any back pain? Sorry, asking the very elementary.
Yes, sir. The patient has a back pain which is mechanical in nature, as well as the VS of back pain is 6/10 and leg pain is 8/10.
If you see the flexion extension view, actually the L4-5 disc is going into kyphosis.
Yes,
if you
sir.
can go back to the flexion extension X-ray.
Exactly.
Yeah, it's going into kyphosis. So this would be a mechanically unstable situation. Going down, taking the disc out, and then having a chance of having a reherniation again. Young 28-year-old person with a sedentary sitting lifestyle, I would probably consider a fusion at this stage. I would do it minimal access via a tube for the simple reason I avoid the scar tissue. The reason to fuse is there is a kyphosis in the disc there on flexion, and this is assuming that this has been done in spite of the patient being in a lot of pain. So if you actually relax the patient, probably the collapse would have, and take the muscle out of the equation, this would be even more. In my hands, I would probably fuse it, since she has a lot of back pain to go with it also.
Yeah, so quick question, Vishal, to put you in an uncomfortable spot. The patient is going to say, why are you fusing me? What is the advantage of fusing me? Will that cure my back pain? How would you counsel him?
So, in this case, the back pain is associated with this disc, and obviously it hasn't gone away with the primary surgery. She never recovered from the pain from the primary surgery. That's what I read. There is an instability. You take away the instability, the chances of the back pain going are very high.
So
nobody can assure 100% recovery. Even when you do a discectomy, I would not assure a patient that there is a 100% chance of recovery from it.
But in a simple nutshell, you would say that I'm doing a fusion and not a discectomy because I want to take care of your back pain also.
No, I would do a fusion because this is a redo in a patient who would probably be sitting for 10 to 12 hours a day. very young and has come back with a reherniation in a very early stage, so has a higher chance to come back again.
So, Dr. Mina, I'm transferring this question back to you. That fusion or no fusion, and if fusion, what is the reasoning that you will give the patient? We don't want to know. The patient wants to know.
So my answer is I never fuse. We have published our results of revision discectomy and re-revision discectomy several years ago, and we have our results of primary discectomy are exactly the same as first time revision and second time revision. So I would personally not do fusion. And particularly,
so the patient says that, will I get a disc the third time if you don't fuse me?
I don't know. So if there is a 5% chance after the index surgery, you have the same 5% chance after the second surgery. The propensity of a third time disc prolapse does not increase because he had a second disc prolapse.
Right. So Anant, we've gone into some gray zones here. Do you think a fusion will reduce the chance of back pain compared to if you didn't fuse? And what about the chance of re-recurrence of the disc?
I don't believe that fusion necessarily improves back pain, and I agree with KV on all the statistics. That in fact I would do for a young patient our protocol is not to do a fusion until at least 2 recurrent revisions have been done.
Right. Last word from Dr. Chahal. Would you fuse or would you decompress?
I would only decompress. It's just a leg pain. The patient already had, already in a big problem, had a surgery, then again pain. So he requires his pain relief and reconditioning of his spine muscles. I think that will take care of his back pain.
Wow. So this is a surprisingly united house. Though personally, I'm on Vishal's side. I would also want to fuse because I consider a recurrent disc unstable situation. But I think the house is very learned, and what they're saying is coming out of experience. Go ahead, Samir. What did you all do?
So in this case, sir, we actually went for a fusion, considering that, as Vishal sir rightly pointed out, there is a subtle kyphotic instability and the patient is having a significant mechanical back pain. A young patient, we did a TILIF in this patient. So presently,
Did the patient ask you why are you putting implants?
Yes, sir, the patient definitely asked. So for all the patients who come for a redo microdiscectomy, we always tell the patient, we explain everything that yes, there's an instability, the chances of recurrence is also there. And most of the time, so what happens is that if the patient is convinced that all the aspects of his pain or her pain will be taken care of, the patient usually agrees for the implants.
But basically, how do you sell your fusion? What is your selling point for the fusion? The fact that back pain will be less, or the fact that you won't get a recurrence at the same level?
Both, but particularly the recurrence. So what we have observed is the chances of a recurrence, the mere fear of a recurrence occurring after a second redo convinces the patient for a TILIF at this moment, and that is what happened.
Any counterpoints from Rupinder, Anand, or KV? Yes.
I think we have to sell ASD also to this patient because there is a rotational element involved in the spine. There is an eccentric loading on the disc above. So it is definitely, we will have a accelerated degeneration.
Dr. Karne, we'd like you to come in at this point because here the patient wants to know that by fusing, will it be my last surgery? And clearly what Dr. Chahal said is true, that there is a potential for ASD that's already staring at you. How do you convince the Puneri patient?
That is I was going to ask, so because the Puneri patients are too inquisitive, that is going to ask me. I tell him two things. One is your back pain is a different part and your radiculopathy is a different part. Your radiculopathy or the neurodeficit which is there will be taken care of by the second surgery. But the back pain is because of many reasons, not because of only this particular reason. So you may get backache in future because of other reasons also. So we cannot assure you backache after this. But then I will go for the fusion as well as the stabilization, because the primary reason why the disc has come out is because of some instability at that level. And so the chance of the recurrence of the next disc is far higher. And we are convinced ourselves that once we have stabilized that particular segment, this prolapse will not occur at least at that level. And we always tell the patient that recurrent surgery will be required. We won't say recurrence at the level. We take that in consent itself, that you will get the backache again and you may get the disc prolapse in future again.
Right. Neeraj, quickly, Neeraj and Bhauk, the Delhi private and the Delhi public hospital version, recurrent disc with not much instability radiologically. Neeraj,
so
fuse or redo disc?
It's only redo disc, sir. In the first...
So there is no instability, only redo disc.
Fantastic. So the house seems united. Let's go ahead, Samir.
So that's it, sir. So this is what we did, and the patient is symptomatically much better as of now.
Lovely, lovely. So let's pass the baton on to Vishal for the next presentation. Vishal.
Yeah.
So good take-home messages from that last case, and a lot of arguments which we don't have answers to. Though we are convinced as to what we did is right, we don't know in the future whether the patient is going to come back with an ASD, and most importantly, how to counsel this patient as to why you're fusing. One of the easy tricks to use is that once you take away the disc, it's not going to come back. So at least that I'm assuring you. And those of us who like to fuse, I'm in the fusers category. I normally use that as my selling point. Yes,
Abhay,
Vishal.
I just
for the
want to have
fusers,
one
Abhay,
opinion of
Yes.
house.
for the fusers category, remember there is a term called the slow march up north.
Yeah. There's always a level adjacent to the adjacent level.
Slow march up north. We keep going up north and north.
I just
Fantastic.
want an
Dr.
opinion
Karne?
of house, because the patient can allege. This is a medical legal part now, because we are always scared in Pune about the possible medical consequence, at least in the spine surgery. So if he accuses you that you have done inadequate surgery right from the beginning, how we can prove that we have not done inadequate surgery? What is the proof?
This is a sensitive situation, and KV, maybe you can come in.
I mean, what's the question really about the legal issue, whether your surgery is adequate or not?
Yeah, I mean counseling
in
to
court of law,
prevent
how
it
you
to
can
go to a
prove
legal
that you have
issue.
done adequate surgery on day one.
Yeah, but I mean, having been living in a state where the consumer court is probably as bad as the Western countries in Kerala, I can tell you from personal experience, also having gone through many consumer cases, the court will ask only reasonable questions. They expect only reasonable care. And it is the onus of the person who sues you to prove that there has been an act of omission, an act of commission, or an act of connivance. So you don't have to disprove anything at all. As long as the patient had relief of symptoms for 3 months, as happened in this case, you don't have to bother at all.
Bhauk, I'm going to come to you on
I will
this.
disagree with this. I will disagree with this, sir.
Yeah.
I will disagree with this because I'm in the medical legal field for the last 4 years. It is the onus on the doctors to prove that he has done a correct surgery, not on the patient.
That is completely incorrect, because I've had roughly 16 cases against me in the court of law in my last 45 years of my career, all of them from Kerala, where I used to practice. And the High Court of Kerala and the Consumer Court of Kerala is very clear. If the patient has alleged a negligence on you, they will have to prove that there has been either an act of omission, an act of commission, or an act of connivance. Not only has there been an act, but the patient has suffered due to that act. It is not just enough to prove that there has been an act of omission.
Dr. Karne, आपण Kerala shift होऊन जाऊ.
Yeah, exactly, because he is very lucky. He is very lucky.
How quick tips on how can you counsel a patient who's getting aggressive when he's come with a recurrent disc? What are the tricks that you use to counsel him and calm him down?
So just one point I would like to make. In every disc case, I keep two things ready. I always store the X-ray of the level, which I use to confirm. I always store it for that particular person. And the number two is we always send the disc for histopathology. We always send it, and we always keep that report that we have removed the disc, nothing else. So if we have two things, we have done the correct level surgery and we have removed the disc, whether it was adequate or not, then the things become later on. And it is very hard to prove, whether the disc you removed is not correct or not. We always keep these
Fantastic.
two.
Great point.
Great point. Yeah, I think what Samir did also was a very good job, because we are not practically seeing the patient, the demand, the sitting pain. It all depends on small, subtle instability, and everyone can be right at their own discretion. There are different ways to skin a cat, and well done job, Samir. We have a talk from Dr. Chahal about when to fuse, and it will be coming after Vishal's talk. Yes, Vishal, please proceed.
Yeah, hi. So this is a 58-year-old alcoholic liver disease patient, 130 kilos of weight. He was on the waiting list for a cadaver liver because at his weight, doing a liver transplant from a living donor was not possible. He was riding a rickshaw. He had a jerk, following which he presented with this. This was interpreted, until this point he had not come to us. This was interpreted as a compression fracture. An intervention radiologist then did, this was the MRI image, and this vertebroplasty was done by an intervention radiologist because one of the primary needs of a liver transplant is an ambulant patient. And considering his poor health, in their wisdom, they went in and did this for the patient. Patient had relief for the first 15 days, following which he came at 1 month. This was the time he came to us with the shell of bone that was encircling the cement there gone away. And that is the MRI. You can see a collection around it. We biopsied this collection and it turned out to be tuberculosis. So now we have this patient who is now for nearly 3 months on bed, 130 kilos, a liver score of 19, or any score above 16 is a patient who needs liver transplant, and biopsy showing tuberculosis. So at this stage, what would be the management according to you? This is where he came to me.
Shivan, the non-TB UK guys, can you comment? An infection post-vertebroplasty, basically.
So yeah, we've got a few issues here. There's an ongoing infection. There appears to be instability. There's a patient who's been on long-term bed rest and his liver is short. So that means antitubercular therapy is going to be difficult to administer. Each of them is going, I think you'll have to involve the infectious disease or the TB specialist to see what, if you've got a specimen, you can send that off for culture sensitivities and seek their advice on what antitubercular therapy to start. In terms of the spinal instability and pain, I think if the patient is now in a situation where they've been in bed that long, then our hand might be forced that we have to consider intervention. But I'd certainly like to see a CT scan, know what sort of bone stock I'm dealing with, and obviously have a lengthy discussion with the patient, because this is not going to be a small undertaking and he's going to be at high risk of perioperative complications, including intra-op anesthetic complications.
But you're thinking of surgery, basically.
Well, if I think here we've got a situation where there's a patient in bed. He's already been in bed for 3 months and the pain hasn't gotten better. You've got active instability, and if he's not being able to mobilize because of that, he's not going to get any better. How much longer are we going to leave in bed? What are we going to say that, he's going to be better in
So that's a fantastic exposition of British diplomacy. Samir, can you comment? Would you do surgery or would you think conservative?
So I would still think conservative at this moment. I mean, tuberculosis comes in various fashions, and you may never know what the results would be.
Okay, sorry, I need to tell one thing before Samir completes it. This patient could not go on rifampicin and INH because his liver was short. He was put on basic 2-drug AKT, which was not adequate. But that was the only thing that could be given in view of his liver problem. Sorry, Samir, to interrupt.
It's a very challenging one, Vishal, and we have to give a lot of deep thinking for each point in this investigations, and multidisciplinary approach is required. That's what I feel. Yes, please proceed.
Okay, so Abhay, can I proceed with this?
Yes, please.
Yeah, so this patient was admitted with a hepatologist who then got rid of the fluid accommodation. We took care of the bed sore. We optimized this patient. That itself took about 6 weeks. And after that, that's what we did for him. The problem with this patient was his INR at the best was 2.5. When we started, it started with 2.5. And intraoperatively, it went up to 4.5. Came back to 3 and all. You can see the amount of blood. Typically, when you do an MIS fusion, the bleed per screw would be between 10 to 40 cc per screw. This patient bled 900 cc total blood loss in this. While the plan was, if we planned to do an open surgery, he would bleed to death by the time we had exposed the spine. So we put in percutaneous screws. What you see here are the handles through which the rod has gone in, and through these holes, we put in this scaffolding to bypass. There was no bone here. We needed to take it out, but we couldn't take it out because of his condition. So we just put you can see the compression fracture here. So we had to skip a couple of levels, and that's what we did for him. This made him mobile. At 4 weeks post this, he started walking the next day after the surgery, because essentially the painful part of his spine was bypassed. After 48 hours, he was a little more stable. At the end of 4 weeks after this surgery, he had a liver transplant. Our plan was once the liver transplant, as you know, takes a couple of months to stabilize, but is more gratifying than a renal transplant because the man can live a near normal life. So at 5 months post-transplant, the patient being on proper AKT for the first time for 6 weeks, where 4 drugs were given to him. After that, we went in from the front and did this. We took out the cement, put in a lot of rib graft, and this is an globus expandable cage that we put in. And we thought, okay, everything is fine. Anybody would want to comment at this stage?
It's
Yes.
basically very brave to go anterior after having the liver
So
transplant.
that
done
was on the
already.
right side. So we went from the left side. So that's not a big deal.
Yeah.
So the
Yeah, sure.
left side was pristine, and we had a surgeon, transplant surgeon, on hand in case we ran into a problem. We went transplant. The
Sure,
surgical access was not a problem at all. It went off like any standard thing would do. It looked pretty good. We started mobilizing the patient. You can see the ICD there. This was immediately post-op what we did.
Any
This
comments on? Yeah.
Vishal, why not this at the first sitting? Because these globus small cages, the cervical ones, you can easily push in from the back.
His INR was very, very high. He was gushing blood. There was no way we could have opened the patient in the front. And a liver transplant patient, anything done in the front would be a problem. And so to go in for to put in an expandable cage at this level from the back was at least beyond my surgical capacities.
What are your critical comments here?
So I agree with Vishal. I would have done the same thing.
Right. Right. Anyone disagrees with this plan? Anyone has a problem with what? Rupinder, you have a problem with what was done?
No, it is excellent.
I-
Only thing is, I'm going in a post liver transplant, post 3 months again. Interior is, I would.
My question was only if we are going to do an anterior support, then could we not have kept the fixation, made it implant dense and kept it one level shorter instead of going to L4? That was the only issue.
No, the whole idea was to put this just as a scaffolding.
Okay.
The
then
L4 was
are you
had a
thinking
cold compression fracture. So we
Okay.
just included that into the fixation so that there is no stress on a previously fractured bone.
Right.
If you see the lateral, I'll go to the previous lateral. Okay, sorry. So this bone has it looks compressed. So we didn't want to stop here because then this would have taken all the run.
Okay. And what size, what rod is it?
This is a longitude 5.5 rod.
Okay, titanium.
Titanium, yes. There are, in India, they don't have cobalt chrome yet.
Okay.
They have it for the Solera system now. So this is what we did. We thought that once it fuses anteriorly, we will be able to take all the posterior construct out, and that would be the end of the story. Sorry. So any other comments, critical comments?
No, that was the reason I asked you about the rod. It's 5.5 rod. And my concern would be because my personal choice would be to fill in such a construct to fill all the screw holes with instrumentation. And I've used a 6mm titanium rod or a 5.5 cobalt chrome rod because there's a big cantilever in the front across the thoracolumbar junction. So my worry would be implant failure in the form of a rod breakage or screw pullout across the level of the old fracture.
Yeah. So unfortunately, we don't have 6mm titanium in any MI systems, nor did we have. This was done in 2014, so we didn't have the cobalt chromium at that time. Also, issue was monetary. This construct at that time would cost him more than 2 to 3 lakh rupees.
Okay.
And a liver transplant patient, we didn't want to drain him of his finances because the transplant itself cost him about 30 lakh rupees.
Right. Let's fly through, Vishal. We are running out of time.
Okay, so this is what he came back within 3 months. The base of this vertebra gave away. The rod broke here. The patient had pain in the back. There was some attempt at union that we could see here. And he still wasn't convinced for the surgery. And this X-rays, as you see here, there's a frank instability. There is the cage is just floating there in the front. And the CT scan also showed nothing growing through the cage, a complete blank there, and some flimsy union here. So, but by this time, the transplant was sorted. The patient was otherwise healthy. So that's what we did. We went in from behind, took out all the screws that were there, filled them up with this construct. At this time, however, I have drilled through this pedicle and put in a BMP sponge in the front. What Dr. Chahal wanted me to do, I put a BMP soaked sponge in the front through a transpedicular approach here. And that's what was the immediate post-op. An entire thing in from behind, we put in a BMP and bone graft. And that's what we got at the end of 6 months. And this was the union we could see at the end of 6 months. This is the cage, and this is the bony mass on the other side of the cage. This is a solid union, and this guy is now 6 years post-op and walking.
Very good.
Incredible job, Vishal. You've done a very good.
There's one more thing left here. This lysis. Fortunately, he's not symptomatic for that lytic listhetic yet. Listhetic segment there, but that's the end picture that we got, and we are lucky enough to get away with this. This is one of the first experiences in frank liver failure patients.
Yeah.
But
Vishal, do you think there was an ongoing infection and you did a someone did a vertebroplasty in that?
Yes, that was what we thought also, that probably the compression fracture was because of the tuberculosis infection at a very initial stage. If you see the MRI, there is no collection. I had put up an MRI in my presentation of the pre-vertebroplasty status, where it didn't look like an infection. It looked like a simple compression fracture. To the credit of the radiologist, it looked like a compression fracture. And he did what he thought.
So he skipped basically the main step of a kypho or a vertebroplasty by not doing a biopsy at that same time.
Other issue was in a morbidly fat patient. Was vertebroplasty
surgery
the
has
correct indication
not
at a junctional level?
Not indicated, but even if he did it, probably if he had taken a biopsy,
it would have. Importance of sending a biopsy of a sample with every vertebroplasty. A lot of issues that came up. And luckily, this guy survived to tell the tale.
Yeah. Very well executed overall, Vishal. I think we will go to the next case with Anand. Will you please share your screen? As we are running out of time, we will have to cover all the aspect of dilemmas. Anand, over to you, please.
Yeah, I'm just trying to share from my computer. That's all. I don't seem to be able to view this. Let me. Give me a minute, guys.
Yeah, because these are the very challenging scenarios, and we have to have a team approach. Talking to the liver team, it must be, Vishal is lucky that he's got all the experts, said expert, along with him at Reliance Hospital in Mumbai.
Abhay,
so,
yeah.
Tell me on Zoom to share screen. Can I load from my Mac desktop directly?
Yeah,
directly.
Sir, actually,
directly.
there's a green button, share
at
screen.
the bottom middle is a green button says share screen. If you press it, we're going to see your screen.
And if you are using a touch bar, it will come up share screen on the touch bar.
No, it's not showing my desktop. That's my problem.
No, I'm on the Mac desktop. I'm on the Mac desktop and I can see it. It's at the bottom of your Zoom screen, a green button right in the center. Do you see that? Do you see participants chat, record, reactions? So in the middle, you'll see share screen. Can you see?
Yeah, I've clicked on that. It gives me 3 options saying Microsoft OneDrive, Google Drive, Box.
Oh, no.
So your presentation is open in what, Keynote?
Not in Keynote, in Office for Mac.
So that application is open right now, or it's not?
Yeah, it's open.
It should actually give you the option.
So quickly, let's move to Shivan.
Shivan, yeah. Please go ahead with Shivan.
Himanshu, if it's possible, can you private message Anand and figure this out?
Yeah.
Shivan, are you sharing your screen? Or can I share? Yeah. Anand started sharing.
Anand sir has started sharing it.
I have Shivan's presentation otherwise.
Shivan has my presentation as well. Can he share it?
Yeah.
It is there,
Sir,
yeah.
you can see your presentation now.
You can, okay.
Yeah.
Sorry.
Press slideshow, so we'll be set.
Okay. Sorry. Okay. Can just give me a guide. This is something. It just seems to have gone. Shivan, can you just do your case first? Let me just.
Yeah, you can close your share, Anand, so that Shivan can share his screen.
Let me see if I can.
Okay.
Meanwhile, can I ask one question? Why the bone grafting is not done on the day one when you are stabilizing it to avoid such complications?
Yeah, Vishal.
Yeah.
When the percutaneous screws were put in?
He's asking why you did not do the bone
So,
grafting.
see, the problem is when you have an INR that is between 3 to 4.5, by the time you open up 2 levels above, at least, ideally 3, but at least 2 levels above and below, that's 5 vertebral levels, the expected blood loss is so tremendous that a person whose liver is decompensated to the extent of 19 score is unlikely to survive.
Not
So
in
the
this case.
blood loss would
For
be
that
in
matter,
liters.
any other case, not for this case. For that
So
matter, in
any other case, so this I'm presenting this as a something that is different compared to a normal. If this was a person where the liver was normal, it is a no-brainer. I would have gone from behind, 2 levels above, 2 levels below. I would have put in screws, gone from the side, taken out the cement, put in a cage with bone graft, and fused the whole thing. But since this patient was not physiologically fit for this kind of surgery, and we couldn't do a liver transplant, which would have made him fit. It was like a rock and a hard place. You do a liver transplant, you can't do it because the patient is bedridden, and you can't do a spine surgery because the liver is bad. So this was a in-way method to just scaffold, make him mobile, get his liver working. Once it gets working, then go and do your index job. I think where I failed was to judge the strength of the bone. To put an expandable cage in the front at a junctional level in such a long liver arm, there is going to be some movement, and the superior end plate of the lower vertebra, that's the L2, failed. The cage gave away, and that's where the rod broke.
Right,
so
right.
If I had to come back to this, I would have, after the liver transplant, gone from the front, put in that cage, put in a graft, flipped him over, and put a fusion now if the patient comes at the same stage, rather than thinking of taking the screws out and giving them a mobile spine.
Well done, Vishal. I think now it is post interval session, and we'll have to speed up. We will go rapid fire now for the cases with more of presentation and one or two important specific comments. Please proceed. Yes, Shivan.
Can you see me now?
Yeah.
Yes, sir. Can you just make it slide view, full screen slide view?
Yeah.
Yeah, yes, sir.
So just a quick summary. This was a 62-year-old man, diabetic, who presented to us with a history of fever and low back pain with a CRP of 250 and a white cell count of 13.2. MRI scan showed this picture. Patient had significant amount of pain on mobilization, but no neurological dysfunction. Shailesh, I'm just going to carry on, not ask any questions, okay?
Absolutely, yes.
So it was quite obvious that the most likely cause of this problem was a discitis. So we sent the chap off for blood cultures. We normally have a protocol that if patients are fit and if are well and not septic, we would not start them on antibiotics empirically. We would try to get a biopsy, and then till we get a biopsy result back, we would cover them with antibiotics empirically, which is what we plan to do. So the patient was positive for Staph aureus. The patient was started on teicoplanin and rifampicin. It's always protocol here to give the patients two antibiotics. Generally, rifampicin or ciprofloxacin is used as a second one because it acts on the slow, persistent, slow-growing growth of these bacteria. Patient was followed up for 1 month, but what happened was, despite his CRP going down, his back pain was progressively worsening. So every time he moved, he had pain, and when he was given a brace, a lumbosacral orthosis, he had a period of relief of pain. So this was the X-ray that was obtained. It's quite obvious that there was a collapse there, which could potentially be producing instability pain. So it was decided to fix him. So as it's very obvious to all the people here that just going one up, one down would make you have a very short construct. With that degree of collapse, just stopping at L5 is not adequate. So the option was to go longer. So the surgeon at that time, this was the repeat scan. This was the CT scan, sorry. So you can see that there's a significant amount of collapse. So one's not going to get a reasonable hold in either L4 or L3. So one definitely have to go up to L2 and L5, which would mean you're spanning the long level. So you can't stop at L5. So this is the surgery that was done. At this point, can anyone comment on this surgery and what do you think?
Yes, Neeraj. Dr. Neeraj.
Abhay, KV, Dr. Chahal, Vishal.
Did they do a decompression and a bone grafting here?
No, the patient was neurologically intact completely. So there was posterolateral bone grafting done, but no decompression was done.
Yeah, we do a lot of tuberculosis like this, but we go a little short and through transpedicular approach, put in a funnel and put a lot of bone grafting in these cases.
Fair enough.
I think, I mean, putting in screws is not going to solve this problem. The compression surface anteriorly has to be reconstructed if you expect the implants on the tension side to hold till the union occurs. The same thing happened to my construct in the previous case. I would go down at the index level, debride it, put in bone graft. I'll probably put a cage with bone graft there, restore the lordosis, and then go in and maybe go in 2 levels above and up to S1 or an iliac screw.
So the reason I'm showing this case is not actually failure at the infection site. It was to answer one of the things which Shailesh had asked me. So in this patient, the points of failure are yes, as we already said, at the infection site, 2 proximal junctional failure across the L5S1. These are the potential areas that one has to look for when one goes into this site. So if you focus on the L5S1 fixation, what the patient has is an L5 screws which are reasonably well orientated and 2 pelvic bolts. But you got a long lever arm across the L5S1 junction. And the second point to note is the screws at the top, L2, are starting to point towards the upper end plate. So all the 3 areas of concern are genuine areas of concern. So this patient carries on. His back pain improved. He had no fever. His walking distance increased and he had no complaint. 1 year later, he comes back with this. So you can see that the top screws have now plowed into the disc space above. And we did a CT scan here, which actually shows this X-ray on the left-hand side shows lucency around the screws of the iliac crest. So the patient had a failure at both the proximal lung level and the distal level. So and you can see that there's actually solid fusion has happened across the infection site. So going to the distal failure, this is to highlight the fact that when you do a fusion across the lumbosacral junction, uh, whether it is for degenerative scoliosis or any fixation of this sort, one of the problems of crossing the L5-S1 junction is a 40% risk of non-union across that junction or problems with the implants. So to avoid that across the L5-S1 junction, one has to think of basically fixation in the form of 3 points across the L5-S1. One is the iliac fixation or the pelvic fixation. The second is the L5-S1 anterior strut, either in the form of an A-lif or a T-lif or a plif. And the third fixation is the fixation to the S1. Now, the question asked was, what about S2? So S2 and S1 are both essentially cancellous bone constructs. They are different to your typical pedicular screws. And the S2 screw actually is a very short construct. So if you just go from S1 to S2, even Chopin has even got a plate which uses the S1, S2 to put screws in and connect it. But it has been proven that biomechanically just adding the S2 screw on its own does not help. So in my book, just going from S1 to S2 is not beneficial. So what you have to think about is these 3 points of fixation. So if you use both an anterior support, a pelvic hold either in the form of an S2 ALR screw or an iliac bolt, and sacral screw, you reduce the chances of non-union across the L5-S1 to less than 4%. If you use any two of the three groups, which is S1, S2 as one, anterior support, plif, T-lif or A-lif as the other, and the iliac bolts is the second, your failure rate is about 15%. And if you only do one, the failure rate is what Suk had published, which is 40%. So this is the point I wanted to make. So when you go across the S1, S2, do not only think of the S2, you have to think of these 3 points of construction. And this CT scan shows the lucency, and this is what we did. Any points?
I think there is no way out at this situation, because the top and the lower bottom, both of them are loosened. It has to be revised, and we have to do the S2 LR as well as go one level above. Any quick comments, Rupinder?
He needs to be unmuted.
Unmuted. You need to unmute, yeah.
Sorry. I think unless until we have that anterior support there, nothing will work. It will fail at all these 3 points which Anand has already mentioned.
You feel anterior support is needed.
Yeah.
But that is fused now at this juncture.
I can't,
I think what he's talking about is that L5-S1 level. L5-S1 level is going to be the junctional level.
So if you see this CT scan, it actually shows that the L4, 5, L3 for the infection level is actually fused solidly.
Yeah. So here, what I think Anand was trying to say was that you need to also do a T-lif at the junctional level at the base at L5-S1, because S1 screws are going to be short, they're going to be in a cancellous zone, and you have to augment it with either an S2 ALR or a iliac bolt with that. Other thing is that the initial iliac bolt was very short.
Yes.
It should at least be a 80 to a 90 mm length. In extremely short individuals, you can take 75, and it has to be at least 7.5, if not 8.5 or 9.5 in its thickness. Otherwise, it does not work.
Well said, yeah. Well said, Vishal, because we always retrospectively think what we have done and we learn from that. It's a very good experience, Anand, and very challenging case. We would like to go ahead as we are having short of time today. Dr. Shivan, please share your screen. As we have Dr. Bhauk, Dr. Chahal, and Dr. Neeraj following this, we'll have to be now in action mode, all of us.
Okay, can you see my screen?
Yes.
Okay, so this is a patient, a 30-year-old gentleman who is fit and well, BMI of 25. He presented with a 3-day exacerbation of back pain, which was radiating to both legs, and 1-day history of numbness in the groin with some difficulty passing urine. No sensory or motor deficit on examination. The PR, there was reduced sensation bilaterally, but normal tone. SLR was positive at 45 degrees bilaterally. So this was the MRI finding so I'll just run through the case, Dr. Adgankar, is that okay?
Yeah, please, yeah.
Yeah, so so we can see that there's L3-4 and L4-5, there is compression of the nerve roots. He also has a constitutionally narrow canal, so this is contributed to by disc bulges at both these levels. So he was consented and taken for surgery, and he had an L3-4 and L4-5 bilateral micro decompression. At the time, the disc was left intact, and good decompression was achieved as per the post-op. On day 1 post-op, so immediately after the surgery, when he woke up, his leg pain was significantly better, but he started developing recurrence of pain on day 1 post-op. He also had new numbness, which is non-progressive in nature, in his left L4 dermatome. There was no fever, but obviously this was a bit early, and his wound was healthy. So at this stage, I mean, initially we were thinking that should we continue analgesics, monitor, should we repeat his blood tests, which we did. And then because the pain was quite bad, we decided to get a repeat scan, with the differentials being a possible hematoma, a recurrent disc, or nerve dysesthesia from the surgery itself. The post-op scan, which was now, so this is day 1 post-op, which we did the scan, in which we can see that there appears to be some compression still ongoing at the L3-4 level. L4-5, we have to appreciate that day 1 post-op, the images aren't going to look great, but you can still see some CSF around the rootlets. Given that this patient's bilateral leg pain was quite bad and he was getting numbness in the leg, he was taken for a revision L3-4 micro decompression and discectomy on day 2 from his index surgery. So the 10th of Feb was his first surgery. On the 12th of Feb, he had his second surgery. And intraoperatively, they also found that there was an organized hematoma on the left side. So on the day after this surgery, in the morning, he reports that his leg pain is improved, groin numbness is improved, but he still had some numbness in his leg. However, in the afternoon, he suddenly develops an acute left-sided foot drop, which is grade 1 power in the Tibant and 3 in the EHL, which is painful. The wound is still healthy and the patient is apyrexial. So once again, we went through the same differentials and the management plan, and a repeat MRI was done again. And now this is day 1 post-op from the second surgery, which means 3 days after the index surgery, where again, you can see that L4-5 level looks nicely decompressed. There's no issues going on there. But at L3-4, once again, there appears to be a acute disc fragment. And this is another close-up of the L3-4. So this is on the left side. And I think these images are similar to what Samir had shown earlier. It's a well-circumscribed mass, which is slightly peripherally enhancing. And so now essentially we're in a situation where a patient has now had 2 discectomies within a span of 3 days, and he's got a recurrent or a residual disc at L3-4 for a second time. And he's 30 years old, young, fit, healthy, good, low BMI. So again, the question comes up, which we had been discussing, that do we take him for repeat decompression and discectomy, or are we now going to consider fusion? And I think the urgency in this situation was that he's now developed an acute left-sided foot drop. So essentially, we went ahead with a second revision decompression and discectomy. The laminotomy was extended, the spinous process was burred, and in fact, 2 extruded large disc fragments were found and removed. And this is the patient 1 month post-op, where we did an MRI scan, and you can see both L3-4 and L4-5 levels are well decompressed, and so essentially, just looking at the literature, because we were discussing this earlier, there are some risk factors for recurrent disc prolapse, which include smoking, high BMI, diabetes, tall disc, and then there's talk about doing an intra-op annulotomy and clearing out the whole disc space, rather than just a sequestrectomy would make the patient at a higher risk of developing a recurrent disc. And in terms of how to approach this after it has happened, there's a lot of papers on discectomy and fusion, but I don't seem to find anything which is comparing the two. So this latest review article by Shepard and Cho in Global Spine Journal last year, he's quoted multiple papers, and all the ones who are talking about discectomy say discectomy is very good, and then the ones talking about fusion say fusion is very good. But what they've suggested is that indications for fusion would be radiographic instability or sagittal or coronal plane deformity. Thank you.
Well said, Shivan, because literature is on both the sides, and we have to be very careful when we select what we are planning, whether we want a revision, decompression, or fusion. A quick comment from Bhauk, and then we proceed with Dr. Chahal.
I think
Yes, Dr. Chahal.
this was a sensible approach which they have done. So I think there is no place of doubt or anything.
Completely agree, Bhauk, because there are the challenging situations. In 5 days, 3 times the patient underwent surgery, first primary, then secondary. And these are very rare occasions which comes in our life, and we have to deal with it sensibly and taking all the...
Sailesh, the thing to be highlighted here is aggressive thinking, and aggressive remedial measures that were taken probably helped them. You should not be sitting on such kind of cases. You should be aggressively treating.
Take decisions, yes. Yes, Dr. Chahal, yeah.
Yeah, I'll go through it very fast. Thank you, Sailesh. This is a 27-year-old female. She's a nursing staff, had a fall in the bathroom and had a back pain. No neurologically, everything okay, just a tenderness over dorsal lumbar spine. X-ray would show an L1 compression fracture. The MRI proves that. And so it's a burst fracture L1 with normal neurology ACI. So most of us, since he is a working nursing staff, would operate, and similarly we did this. Most of these cases we do percutaneous stabilization. So this it was done under general anesthesia, short time, and nothing uneventful. So immediate post-op fixation, height restored as it was fresh fracture. The problem started on the 3rd post-op day, severe back pain, serous discharge from the right lower L2 pedicle wound, and 5th day, even on the left side, it started oozing. So she developed hyposthesia on the back, paraspinal muscles, low grade fever, lab studies, all are normal, only TPK was raised.
Hello.
Started on empirical.
Yeah, it was good. I think
empirical intravenous
tied in
antibiotic.
very well with the case that they showed of doing.
But discharge continued, and now the pain on the 10th day, the pain had settled. There's no fever, hyposthesia persisted, but then the discharge was still there. So we took her to the operation theater, removed all the sutures under general anesthesia, put in a suction tape and syringe, washed it well with copious amount of saline, and we thought everything was okay. But then the discharge still persisted. Now then she was a little irritated as she was the hospital staff. Then we decided to explore it, open it up, and we did a midline incision. Entire bilateral facial tracts were explored. The paraspinal muscles were pale, avascular, non-contractile, dead. It was something like what we operate as VIC. So dead muscle was excised till a vascular bleeding was seen. Biopsy showed that it was a chronic inflammation area with necrosis. We did search the literature and came to know that this was a post. She was all right, and after that, and literature we compared it. It talked about something called a compartment syndrome of paraspinal muscles. Luckily, it was in 2013, and I had not heard of it. I had never read it. Paraspinal compartment syndrome post surgery. Then. So he looked at the relevant anatomy, look at the thoracolumbar fascia and how it divided the back muscles into 2 tight compartments, and how an procedure would lead into a bleeding there, muscle damage, and tissue swelling, increased compartment pressure, decreased perfusion, hypoxia, cell membrane damage, and this vicious cycle would go on. So there were 8 articles. We looked into it. They said the normal compartment pressure was between 3.1 to 10.8. Then we have to measure this. We didn't do it in our case because we were ignorant about that fact. Pressures vary with different positions. And even Senthilnathan divided it into two types and half fitted into direct trauma to the paraspinal muscles. And patient generally presents with bilateral unit paraspinal rigidity or hypoactive bowel sounds, local sensory loss, and SGOT and CPK are elevated. You get urine myoglobinuria and they're elevated intramuscular pressure. The MR picture would show a homogeneous increase in signal intensity on T2, but very difficult with the implants in to look into this. So conservative management is the first line, including pain control and control of rhabdomyolysis by giving a good IV hydration. And but you have to decompress the compartment as early as possible to prevent a long-term sequelae. So we looked at, this was the first case reported post minimum invasive percutaneous screw stabilization. So important take-home message is lumbar paraspinal compartment syndrome should be considered in differential diagnosis. Surgical decompression of compartment as early as possible is required to avoid long-term functional sequelae.
Very, very interesting case, Dr. Chahal. I just would like Dr. Vishal to quickly comment on this. Yes, Vishal.
He's already covered all the relevant points. One of the things to avoid getting into this scenario is to see that the patient doesn't have any bleeding deranged parameters. Second thing is dehydration. Third thing is to take a cut right deep to the deep fascia. A lot of times, especially at dorsolateral junction, the rods end up going superficial to the deep fascia. And then as you try and reduce the rod, in young patient, you can probably reduce the rod to the screw, but it causes a lot of crush factor of the muscles leading to rhabdomyolysis. So your rod the tip has to touch the base of the screw and then it has to be bent. That's one of the tricks, but having said it, you're still going to see 1 in 100 cases like this happen.
Yeah. Bad luck.
Well done, Dr. Chahal. You have the quick case ready or?
Yeah, it is there if you want.
Yeah, quickly, one and a half minute. We'll just go rapid fire. Yeah.
This is a typical L4-5
syndrome. Has a compartment syndrome occurs in the open case. This was a scopic case. Has any time it's happened in the open case? Compartment
Yes, sir.
syndrome.
Yes, sir. Absolutely.
Yeah. So this is a L4-5 disc with left leg pain, normal neurology. So a surgery was done and uneventful, but after 4 weeks, patient came back with the same leg pain, no fever, again a normal neurology. So we have already covered what next to do it. Blood test to definitely look into if it is an infection or not. This case had raised inflammatory markers, whereas TLC was normal, blood cultures were normal. X-ray, very, very important to look at the level, look at the erosion of end plate, look to rule out early infection. But the gold standard still remains an MR, which will give you a clue about all of this. So a repeat MR was done, which showed a T2 image, focal hyperintense lesion in the left lateral recess and with the surrounding of a hypointense smooth margins. So this is the T1 picture. So we had not done a contrast. Ideally, you should do a contrast in this. Pavak has already highlighted that. We were discussing with the radiologist. They said what it can be. I said we do pack this area, so it can be a cottonoid. So they're doing a internet search there, and they took out this radiological picture, which did resemble our case. So cotton granuloma after surgery, and so we were anyway. I was planning to get a contrast done, but looking at this picture, I said I will first of all get the patient to admitted and just go in for the surgery before he goes somewhere else and patient comes to me with the cottonoid. So we admitted and opened up. To our surprise, we saw a small amount of loculated pus at that point, and it grew a Stenotropomonas maltophilia. This is something very rare, normally found in immunocompromised patients, and only 4 or 5 cases are reported in spine. And this is a gram-negative bacteria, and it requires a prolonged antibiotic treatment. So this we give 6 weeks of IV and 6 weeks of oral antibiotic in this case, and patient was all right. Thank you.
Yeah, thank you, Dr. Chahal. It was an interesting one, and right decision at the right time probably has given you a good answer. You want to talk about 1 or 2 minutes about this fusion?
Yeah, 2 slides I put it for you.
Yeah,
The
yeah.
role of fusion in disc surgery. So define the indication of anticipated surgery preoperatively. This is very, very important that when you're going in for display, you must know whether you're doing a fusion or not. So what is important in this, you must look at is the instability. One is a overt instability. There is no confusion. You look at, there's a translation, there's the angulation. You do a discectomy, you do a fusion, whatever you do, TLIF, TLIF or ALIF, that's up to you. But important thing learn from this is to look into this probably as of now, I have now started doing is doing dynamic x-rays in all my lumbar spines. Whenever you do a normal investigation, I always ask for a flexion extension. Even in the absence of a clinical instability catch or a prehension site, I do flexion extension in all the cases. Another is anticipated instability, high lumbar disc. There is a less space to go and take out a disc. High lumbar discs are more prone to being calcified hard discs. Associated congenital stenosis, again a technical problem. Recurrent disc, in my practice, what I've seen is either they follow two patterns. Either very early there's a recurrence that is easy to do it, or it occurs after some time. There you really need to anticipate and plan your surgery, whether you could do it without damaging the dura or the root, or you need to go through a big virgin territory, take off the facet and fix it. So that is, I think, mainly a surgeon dependent thing. And a little bit contribution is the morphology of the recurrent disc. So to avoid all this and plan a better approach, if you can't it, so best is to fix it. And then associated with low back pain. So you really need to know if the patient has a discogenic pain, there's already an internal disruption and there are end plate changes, or there's a facetal loading leading to synovitis of arthritis. And certain people do attribute that even in type 1 modic changes with inflammation around, there's micro instability and you should fix these things. But what I've seen is there are cases, a patient is with a low backache, develops leg pain, low backache disappears, leg pain persists. So they do well with discectomy. There's another lot of patients with low back pain and leg pain, develop leg pain, but back pain still persists. So these are the cases which will benefit from fusion. So then looking at the type of disc, large central disc, hard calcified disc, large central disc, how do you know it? There's a complete cutoff of MR myelo. The patient generally gets this bilateral radiculopathy or a cauda equina. And if you take out these discs, you will have a vertical segmental instability. A hard calcified disc, again, we have encountered is a two type, where this one type you will have an annulus, which is just a calcified. When you take out that hard mobile thing, and you will have to go very medially to take it, you have to use at times carry some rongers to cut that bone. You will create instability. And there are places where there is the whole disc is hard and calcified. You don't need to touch the disc. You can just do a foraminotomy and decompress the root. That is enough. The patient factors are obesity. You must consider in all cases whether this patient would benefit or create instability because of his own weight. Profile of the patient, is it a hard laborer, manual worker who needs a strong spine? Facetal trophies, and a real alignment of the facetal joints is very, very important post surgery, whether they would go into a slip or not. These are the factors which you should take into consideration before considering surgery. I think
Yes,
it's
well said,
important
Dr.
that if you do it before starting the surgery.
Very well said, Dr. Chahal, in quick elaborated. I would like Dr. Neeraj to proceed and share his screen, please. Yeah, Dr. Neeraj. As we are covering up most of the important dilemmas, and Dr. Neeraj will be talking on post-operative leg pain, because this is a very sensitive topic for all of us. Yes, Neeraj.
Am I audible? Can you see my screen?
Yeah.
Yeah, Neeraj.
Yes, this is stepwise. Thanks, Saresh, for the invitation. The topic is stepwise approach to the post-operative leg pain after spine surgery. I will go directly to the case now. So the case is a 34-year male with low backache radiating to left leg since 4 months. Patient was having leg pain more than back pain, antalgic gait, left L5 radiculopathy, SLR positive, or otherwise all neurology was normal. X-rays, nothing significant was there. There was no instability, no lysis. So this was his MRI. MRI showed L4-5 large extruded disc, paracentral disc, and I think it explains his left L5 radiculopathy. So conservative treatment was done for 3 to 4 months, but the pain was gradually increasing. At present, patient was not able to walk more than 100 meters, so surgical option was given. L4-5 microdiscectomy was done. Extruded fragment was removed. There was no intraoperative complications. There was no dural tear, no CSF leak, anything else. Post-op day 1, patient was comfortable. There was 70 to 80% decrease in pain. Neurology was intact. Patient was mobilized. On day 2, patient was much more comfortable walking around in the hospital and he was discharged. Now, 3 days later, that is the 5th post-op day, patient again comes with severe pain in left buttock. So patient was having severe back pain relating to left thigh. Patient was having increase in list, but his neurology was normal. So going quickly through to the most of the common causes of this post-operative leg pain. First thing is the pre-operative risk factors. In which patients you will anticipate poor result. So are the patient with mild to moderate intensity of pain, non-specific symptoms, hip and SI joint pathologies, and prior spine surgery, and depression, psychosomatic illnesses. And intraoperative events, we all know that the causes of leg pain are wrong level side, then inadequate decompression, aggressive decompression causing spinal instability, malposition of screws, missed pathology, battered root, neural injury, dural tear, and overzealous reduction in high-grade listhesis. And the post-operative issues which can cause post-operative leg pain are early are the epidural hematoma, post-operative infection, recurrent herniation, and the late causes are screw loosening, epidural fibrosis, pseudomeningocele arachnoiditis, SI joint dysfunction, and spinal instability. And as per literature, the causes of immediate failed lumbar disc surgery are mostly recurrent disc, hematoma, and battered root. So the first thing is, okay, so I'm not asking questions, just describing it. So what are the main things which you will see, like to elicit in the history and clinical examination at this stage when the patient comes with the post-op leg pain is the first we have to see the site and site of pain, onset of pain, whether it was gradual or sudden. And the most important thing amongst this is pain-free interval after surgery. We have to ask about the pain-free interval after surgery, whether the initial after surgery the pain has been relieved or not, for how many days pain was relieved, or the same pain has been continuing. Then protocol, we get all investigations done. So my question, I'm not asking, but there are different protocols, like when to do MRI. Do we immediately do MRI, or we have to wait for some days, do conservative management, then do MRI? So that house has to decide. So all investigations were done, and after investigation, 3 type of common scenarios are there. In scenario 1, there is nothing significant on X-rays and MRI, which is the most common. In this patient, MRI only post-op changes are there. X-ray implants are all normal, and sometimes minor issues are there, like mild residual disc fragment, foraminal stenosis, or grade 1 cortical breach by screws, early cage migration, early infection size, and major issues. And the major issues are the recurrent disc fragment, discitis, or implant malposition. So in the management protocol with no or minimal pathology, we have to reassure the patient, give rest, NSAIDs, pregabalin, transdermal patches, steroids. I have to ask whether we should give steroids or not. Then nerve root blocks, SI joint infiltration. So indication of re-exploration, we all know, bowel bladder involvement, profound motor weakness, progressive neural deficit, and persistent pain. So now we did MRI in this patient. This is the MRI picture. In this MRI picture, Shailesh, can you comment on this? Anything significant you can see in this?
Yeah, I can see that there is a slight inferiorly migrated disc we can see in the sagittal, and we have to be very careful when we see this kind of picture, whether there is a scar tissue, residual disc, or recurrent disc. All these things we have to clinically balance and check along with the MRI. Yes.
Yeah. So actually, while doing the 3 days back only, we had done the surgery. We were quite satisfied with the disc fragment, that we have removed all the disc fragment and root were adequately decompressed. So we could see a small hematoma here. So we could see here a small hematoma going down. So we just we were not sure about it. So we just this was a lot of T1 images. So under all aseptic conditions, we put a spinal needle was put along the spinous process. Aspiration was done. 10 to 15 ml of bloody fluid was aspirated. Suddenly, patient had a great relief in pain. 70 to 80% of the pain was decreased, and tight bandage was given and rest advised for 10 days. So literature also shows that the prompt surgical evacuation of postoperative symptomatic hematomas lead to resolution of symptoms, and emergency evacuation should be performed if there is a good correlation. And asymptomatic epidural hematomas are in 33 to 100% of the cases, and symptomatic are rare, but can sometimes cause devastating consequences. So I just wanted to ask only one question that was regarding steroids. So in post-op leg pain, how many of us are giving steroids before doing MRI or any other investigations? Anybody giving steroids, or how long you do conservative management?
No, I think it is important when there is a complaint of post-op leg pain. We have to always check what is the reason, whether there is any infection or something. What is the reason for it? Whether there is any pus or hematoma or any recurrent disc.
So that means on day one only you will do the MRI, or you will wait for some time for
we will wait for this, because sometimes there can be a neuropraxia which is causing this. Anything can cause this. So immediately I will not do MRI. And
There are some clear-cut red flags of post-op leg pain, like a new pain or a worsening of pre-op pain, opposite leg pain, neurology with pain, or dermatomal distribution of hypoesthesia. If any of these happen, you definitely want to investigate quite soon. If this is not a red flag leg pain, you like to wait and watch, but try not to give more medication and counsel the patient. But one thing's for sure, that you want to do an MRI before the next surgeon asks for an MRI scan.
no, his question is, day one, will you do that? After one day, he complains.
If there are no red flags, you would not do it on day one. But if it's red flags, you would. I have done on day one when a patient developed a toe drop with leg pain post-op. A new neurology post-op with leg pain.
Dr. Abhay, actually, if you do the MRI on the first or second day, in most of the cases, we do see only post-operative changes, and it is very difficult to decide what is happening there.
Yeah, but I think we can interpret it. When we do that MRI scan, we are going to interpret it, and we are only looking for a space-occupying lesion there.
Okay.
Yeah, it's in a very specific scenario, but not most of the times. In 95% of the time, we don't do MRI in day one. The patient complains of pain, we have to assess whether our decompression was good. Most of the times, there can be various factors. Nerve root is free. It can hit on the exit area, and it also can contribute to pain. Maybe in very specific instances, as Dr. Nene is talking about, where we do MRI on day one, but normally we can wait and see. If it's not settling, then probably yes.
And any role of steroids?
Yes, Abhay sir.
I would not give steroids if I don't know the diagnosis.
No, if the nothing is, if the only minimal only post-operative changes are there on MRI, and you feel it's only a neuropraxia, in that case you will give steroids.
Definitely give steroids.
Okay, you prefer to give oral steroids or IV steroids?
Depends on the type of pain. Basically, if it's a uneventful surgery and there's no cause for pain, and the patient is indoors, we even give intravenous methylprednisolone.
Yes. Okay, comment, Shivan.
So I think for root-related pathologies, we wouldn't typically give steroids. And that's also a lot because things are monitored here. So our physicians get very upset if we're giving. And especially after even the nastiest trials and all, we really struggle to get steroids to patients who even sometimes with cord injuries or if there's something in that situation. So no, steroids won't be a part of our protocol. Going back, Dr. Neeraj Gupta, about your question about scans post-op day one, in the case that I demonstrated as well, there were clear red flag signs. That's why there was in the first day, he had a new numbness, perineal numbness, which we had to scan for. And then the second time he developed an acute foot drop. And in those situations, I mean, the scan, I think like Dr. Nene said, we do need to do it.
Yeah, point taken. So if any of the red flags are there, then we should do immediate MRI. Otherwise, we can wait for 1 or 2 days.
Yes. Okay. Well shown, Neeraj, very nicely.
Sorry, I was very fast.
No, that's okay. But you covered most of the points which are relevant. I would like Dr. Bhauk to share his screen, please. Neeraj, you'll have to close your screen.
Neeraj, you have to stop sharing.
Yeah, I'm doing that.
Or you can leave meeting and come back, join again.
Okay.
That's easy. But what Dr. Neeraj has covered is very good in very less time. Yes, over to you, Dr. Bau.
So I will be presenting a case which was a great learning experience for us. So she was a 35-year-old female and she had a history of typhoid, maybe around 18, 20 years back. She presented to us with the neurological claudication on walking around 100-meter distance. She was having back pain, which was quite significant. And she had bilateral symptoms and the right was more than left. And we made a diagnosis of lumbar canal stenosis on the basis of the imaging and the clinical findings. So you can see these are the x-rays. You can see L4-5. There's a bit of kyphosis as well at this level. And this is the MRI pictures. You can see body changes, stenosis, as well as there is a facet synovitis at this level, L4-5. So we did a standard surgery, open TLIF from right side with decompression. And this is the post-op X-rays, which look fairly okay. And these are the post-op CT scans, which we usually do in our every case in which we put implants. So post-op course, doing fine for the first 5 days after surgery. She was mobilized, her symptoms were relieved, bladder and bowel, everything was normal. She was discharged on the 6th day. And on 8th post-op day, she presented to our emergency department with abdominal pain, abdominal distension, with sluggish bowel sounds and fever for the last 6 hours. And abdominal radiographs, they revealed gas of the diaphragm. So what could be the possibilities? So again, we did obviously there was gas in the diaphragm, so we did an explorative laparotomy, and after the peritoneum was opened, a gush of air was seen and a sigmoid colon perforation. A rectosigmoid junction was seen in the sigmoid colon with embedded bony fragments with sharp spicules. You can see, the sharp spicule of the fragment which was there, which was embedded into the sigmoid colon wall. And so the question was it an intraoperative injury or it was a post-operative injury? So intraoperative was no, because she had normal post-operative 5 days without any bowel symptoms. The approach to the TLIF was from the right side, while the sigmoid colon is much below the L4-5 level. It is near the sacrum and is much below and towards the left side. It was not a complication of hardware placement, as post-operative CT scan ruled out this possibility. It was an open TLIF, so there's no possibility of injury via guide wire. And the question was due to some pre-existing typhoid ulcer. Yes, we kept this possibility that surgery is a stress phenomena and these typhoid ulcers, they can perforate. But actually, when we saw the intraoperative findings, it was clearly because of bone fragments. And in the CT scan post-op, you could see that there was no bony fragments anterior to the spine. So actually, we saw those bony spicules. They were embedded inside the perforation. They were removed and the perforation was closed and the loop colostomy was performed. Patient was discharged in stable condition on 3rd post-op day when she was allowed orally and the fever was subsided. Final procedure of closing was done after 8 weeks. Colostomy was closed, but she developed incisional hernia, which was again repaired after 4 months. And she's now around 44 months in follow-up and she's now doing fine. And these are clinical pictures. You can see the telltale scars of the horrible story which she had to undergo. And we published this in 2017. So basically, the spinal surgery, they can be associated with complications which are rare, and bowel and vascular injuries intraoperatively has been reported. People have also reported dislodgement and migration of graft as well as the cage, and the late migration of graft after a year or more so after the surgery, but has also been reported, but this was done through the anterior approach. So there was no report of as such from the graft migration after the posterior approach. And people have reported the visceral perforations after lumbar disc surgeries, and the majority of them are the small bowel injuries because it is in the immediate vicinity. The large intestine perforations, they are quite rare. And Roof has described the perforation of sigmoid colon due to intradiscal spacer dislocation 4 years after the anterior endoscopic implantation of spacers. And one author has also described a case of cecum perforation after L5S1 PLIF with the femoral graft through the anterior approach. So again, all these, they were through the anterior approach. So the true incidence of bone graft migration is not known actually in lumbosacral spine, especially after the posterior surgery. Factors that can potentiate graft migration, they include insecure placement, segmental instability, tear in the annulus fibrosus, damage to the ALL, too much disc resorption, and excessive curettage of this material. So to solve this problem, the people have also described that you mark your depth marking of the instruments. You first feel ALL, see how much depth you are going, then mark your instruments that you don't have to go more than this depth. People also have described saline tests in which you put saline after you have done discectomy, and then you just aspirate it. If the amount of saline aspirated is less than which you have injected, too much difference there, then it means that the saline is going anteriorly and there are chances of anterior defect. So high index of suspicion is also essential. So retrospectively, if you look at the MRI of this patient, you can see that there is anterior disc herniation. So now this anterior disc herniation is actually a risk factor that signifies that there is an ALL incompetency. So whenever you are going for TLIF or this thing, so you should always look for the preoperative MRI, this ALL incompetency in the form of anterior disc herniation. So one has to be very careful with your instruments and putting graft. So we don't put graft now if we see this anterior disc herniation anterior to the cage. Thank you.
It's very well done case, Bhauk, and very well reported also. Very good take-home messages. Very unlikely we see, or very uncommonly we see anterior defects and anterior longitudinal ligament rupture leading for anterior weakness. Yes, Abhay.
It is something that we all as surgeons should be ready to tackle, because it can happen when you're caught napping. And I have had two major vessel injuries, but both have been introp. There has been one delayed reason to explore, but the injury was still introp. And I think what Bhauk presented is extremely exotic. So I think it's full marks for picking that out.
Yeah, Bhauk has one more rapid fire. He can fire that case. Yes, Bhauk.
Yeah, just a moment. So actually this case was presented as a special case to be presented at NAS in the Spine Connect meeting. So I think I can give some good message from this case. So it was a 30-year-old male, and he has got severe radiating pain in the left lower limb, which was going towards the lateral aspect of the foot. He had no back pain, and he was having this problem for the last 2 months. He has exhausted all conservative treatments. There was no relief. Power was okay. There was no sensory deficit. On the left side, the SLR was 50 degrees, and there was a femoral stretch test was positive too. And this is the MRI. So you can see that there is a L3-4 disc herniation, and there is an ulnar tear at L5-S1 as well. So again, these are the X-rays, which look pretty okay. Any other investigation we could think of? We got the EMG NCV done because there was pathology at two sites. Because clinically it was S1 radiculopathy, but on the MRI it was L3, L4 disc herniation, which was more significantly looking on MR as compared to the L5-S1. So it reported L5-S1 radiculopathy. Now we agree that the L3-4 pathology can also affect only the L5-S1 nerve roots because they also pass at the same levels. Discography is of no use. We have reported it as well in the spine journal. There's a role of flexion extension X-rays in this patient. We got this done, and they were all insignificant. There was no instability on this X-rays. So the question was, which one is the culprit, L3-4 or the L5-S1? So the annular tears, we looked at the literature, and people have described them of significance, clinical significance. They are not just incidental findings. They can be of significant clinical concern. They are specific predictors of back and radiating pain. There is also high rate in asymptomatic individuals, and there are irritating effect of chemical mediators produced by nucleus pulposus. They can leak through the annular tear. So they can also be a source of problem. So the question was, what next? So either we could choose more physiotherapy, chiropractic manipulation, we could give oral steroids, epidural, selective nerve root block, or the surgery. Since the patient was having problem at 2 levels, so we, instead of giving selective nerve root block, we give the epidural in this patient, and there was no benefit again in this patient. So people have reported that the caudal epidural block is an easy and safe method with better, it's a randomized study than selective nerve root block. However, it is technically more demanding, and there is no report as such on multi-level disc problems if we look at the literature. The surgery options were either we go for 2-level decompression, either we go for single level. The question was which one. The fusion we have to go or not. Either we can do some indirect decompression, or we go for disc replacement or anything else. And then we can talk about different sorts of EBM, evidence-based medicine, experience-based medicine, economy-based medicine, or endoscopy-based medicine. But actually, the lumbar annular tear, if we look at in the absence of nerve root compression, is the discectomy useful? So the people have reported that there is a benefit of microdiscectomy in the presence of annular tear also, even in the absence of a clear nerve root compression. And the annular tears, they can be a source of significant problem. So we discussed all the options with the patient, and we had a thorough conversation and discussion. we gave him an option of L3-4 left discectomy and if required L5-S1 left decompression in future versus both at the same sitting. So patient opted for both at the same sitting. So we did an L3-4 fenestration discectomy. Nerve root was quite mobile. A distinct fragment was seen and fragmentectomy was done. L5-S1 space fenestration, again we did. Nerve root was inflamed here. It was angry looking. It was adherent to the disc space. And on mobilization of nerve root, some tiny disc fragments were seen, which were taken out. So actually on the surgery, we could say that probably the L5-S1 ulnar tear was the cause of his pain, not the L3-4 disc fragment. So now he's completely asymptomatic now, and we have around 35 months follow-up of this patient.
Great case. Thank you, Bhauk. It reminds us of the PG question of what is the disappearing disc of Dandy. And maybe this is alluding to that. A disc that pops out when loaded. And when you offload and do an MRI, you just find a little slit in the annulus. Thank you so much for throwing light on a very rare situation. And to conclude today's session, may I call upon the captain of the team, Dr. Shailesh Hadgaonkar.
Yeah, I'll just quickly share the screen.
So far, very, very interesting cases, right from infection to implant failures. And we've had a lovely day. And we're going to end up with Shailu's cases.
Yes, thank you all. We'll be quickly wrapping up with few interesting cases so that we complete the circle. 45-year-old female complains of back pain, both lower limb radiation, difficulty to walk, significant pain. Left-sided pain was significant, and this is what was her first surgery. Elsewhere, she was operated twice, and this was her first surgery X-ray where the TLIF was done. We do not have any details of this primary surgery, but if you see the cage is not sitting very well, it is looking very, very movable cage we can see here. The patient was with persistent leg pain, and that was the reason. Probably the previous surgeon tried to remove the screws, and again, probably they have done a decompression. And this is what the patient comes to us with the scenario, and severe leg pain now, difficulty to even walk some for less than 100 meters. If you see the MRI, we did all this, and we see the left-sided foramen was severely compromised. And if you see very carefully, this is what was the problem. Now what? Because twice done, and again, severe leg pain, we have to be very careful when we see these kind of situations. And either we can push the cage anteriorly, or we have to take the cage out. And we have done a couple of surgeries like this, and now our experience is maturing in this. We normally prefer a Wilsey approach. We go from the side, and we have to be doing a very careful fasciectomy and clearance here. We have to identify both the roots exiting as well as traversing, and reposition the cage in a right way. We removed that previous cage, and this is where we have used a peak cage, placed it anteriorly, compressed it, and now she's lucky, she's doing completely fine. The leg pain is gone. The leg pain took time, 2 to 3 weeks to settle, but it settled very well. Similar situation, 60-year-old patient operated elsewhere, broken implants in situ. Again, severe pain. Initial surgery was done, and if you see the placement of cage, these are the situations which are encountered by all the spine surgeons in their practice, and they are challenging at times because when the patient comes with persistent pain, they are mentally not prepared to undergo another second surgery or third, and this patient underwent 2 surgeries. First decompression, second was this where there was implant breakage at 3 months and persistent pain, and when we did the MRI, there was infective focus at L5-S1. How do we revise? Third time, again, dilemma, but it has to come out. Antibiotics will probably not will help. We did all the investigations, CT, MR, blood investigations, and we planned for a revision similarly where we debrided completely. It came out to be Acinetobacter, and patient settled with antibiotics after the revision, decompression, and stabilization. And now it is nearly 6-8 months. She's doing absolutely everything fine. Elderly lady, 70, rheumatoid arthritis, grade 2 to 3 enterolisthesis, osteoporotic, high grade, again, severe pain, cannot stand, no deficit. All these are the challenging scenarios. We have to be very careful. A lot of non-medical treatments already dried up, and she was not better. There are the challenging scenarios where we can do this transpedicular, transdiscal, transcorporeal TPDC technique, what we call a delta, and the purchase, we normally aim at anterior superior angle. That was not getting very good purchase, therefore we slightly directed inferiorly. Again, there are the challenging scenarios when we see young patients coming to the clinic with this kind of high grade listhesis. They are the dilemmas whether we should reduce, we should just fix it in situ, or we should try to get the sagittal balance, or we do the Bob Gaines procedure, Kellogg speed. All these are the different challenges, but we can get away if you do a good posterior release, good distraction. These are the surgeries we can really do it very well under the neuromonitoring. We have to understand the all nitty-gritties of these kind of challenging surgeries. And if you do a good decompression, distract it higher above, that is what we normally prefer these days in this kind of optosis cases. You do a good release and you can really get away with very good outcomes. And you may get some kind of neuropraxia if you do a very haphazard distraction or incomplete nerve root clearance. There are chances of foot drop in these kind of cases. We have to be very careful. You have to counsel the patient, explain the patient, because they are very young patients and they really do well if you do a good job. Again, this is a patient who was operated twice elsewhere in 15 days, but the patient's preoperative pain did not get better. There was a lytic listhesis, and this is what was done elsewhere. The patient was with severe pain, and when he came to us, this is the MRI, and the previous surgeon felt that it is the screw which is causing the problem. Therefore, they revised it and probably tried to do some decompression, but the interbody area and the instability was properly not tackled, which was probably the reason. As retrospectively, it is very easy to talk about, but the surgeon has done a good job, but the patient's pain did not settle. When he came to us, we thought of giving a pain block. We did a pain block as the pain was 9 on 10. When patient went home and came back in 2 weeks' time, where we had no option but to re-explore, do a interbody, and it really settled very well. There was incomplete nerve root clearance also at that level. That was probably the reason for this pain which was persistent. 62-year-old man comes to us with bilateral weakness in ankle, difficulty to walk, and severe pain, lumbar kyphosis, twice operated. Again, there are challenges, there are dilemmas. What we should do, just we do fixation. How many levels should I do? Because there is 3-4 levels. Lumbar kyphosis, previously operated, moderately obese. All these things, we have to have complete whole spine x-rays. We have to have CT scan, decide, and we have now a good experience of this lumbar kyphosis where we do multi-level osteotomies and releases where we can get away with these kind of challenging scenarios well. And no one is right or wrong. Everyone has a way to do, but these are nowadays very commonly seen issues in our practice where we are seeing more and more this kind of lumbar issues in with dilemmas where we have to deal with them practically. Over to you, Abhay. I will be happy to.
So thank you, Shalu. It was a fantastic session. And as everyone can realize that spine surgery doesn't come in a menu or in a cookbook. Every case is very, very different, and we just learn and we live. So we chose today to bring out only cases and not talk to you about theoretical, gibberish. And we got the best guys on the table. Thank you, Dr. Karne, for allowing this and letting this happen. We are grateful to you. Thank you, Dr. Shailesh Hadgaonkar. You're the dynamic force behind this entire session. And much thank you to our learned faculty, because without you guys putting out your bad cases out there was no way that we are going to learn, and we are going to keep making the same mistake again. So thank you, Vishal. Thank you, Rupinder. Thank you, Samir. Thank you, Shivan. Thank you, Bhauk. Thank you, Neeraj. Of course, Himanshu and Ashok Sham as the pillars of this show. We learned how to deal with re-instrumentation, the causes of failure of instrumentation, how to deal with post-op leg pain. We talked about CSF closures. We talked about lumbar canal stenosis and its pathology. We talked about the biomechanics of implant failure, how to go to S1 if you have to. So a lot of things were discussed, but of course it's never enough. So until next time, we'll call it a day. And thank you, Pune Orthopedic Society, for having us over. Thank you again.
Thank you, everyone, for being there and spending your precious time. See you soon. Stay. Thank you once again.
Bye, guys.
Thanks. Bye.